So we'll take a couple more minutes for the attendees to join, a little more time for them, and then we'll start.
Are you seeing one of the pictures on the panelist? I'm not able to see in the picture. Can you just put a voice? Yeah.
Is that?
Yeah.
Yeah. Can you just, can somebody just call Dr. Palmukar and see if everything is okay?
I think I'm there. Yeah.
So it's not. A very warm welcome once again to all the delegates, all the esteemed faculty who joined us today and who joined us yesterday too. So we had a wonderful, fantastic first day yesterday. We had lots to learn. I'm sure all the delegates learned a lot. On day two also, we have a very good and interesting session on urology, on nutrition and dialysis. Before, we would not have time at the end of the session to do this, but it's really, really important that I thank all stakeholders and mentors today. We had excellent faculty, we had wonderful delegate participation, we had the amazing support of IPNA, ISPN, NNF, and IAP. I thank the Mehta hospitals, the family and the administration, the departments of neonatology and pediatric nephrology, departments of adult nephrology, especially Dr. Edwin Fernando, and the Department of Pediatrics, especially Dr. Tangavelu. But more thanks to all these here, Mrs. Angel from our DRM, the IT team, Mr. Shiva and Mr. Sashi Kumar, our design team, Mr. Sendil, and the housekeeping. It might look like bragging, but yesterday we did really, really well. We had over 1,300 registrations, of which almost 50% were able to attend. And we, at one time, we had a consecutive attendance of around 434, which I think is really, really excellent. It goes to speak about the strength of all the faculty here. We had, again, this is all our faculty. Really, really thank you for all of you for being here. Really appreciate your time and energy for this meeting. And this is the team behind all these endeavors. A big thank you to all of you. I think with no further delay, we can go on to the proceedings. As like yesterday, my fellow Dr. Pooja will be conducting the proceedings, and I will hand over the proceedings to her.
A warm welcome back to all of you. Before proceeding with the scientific session, I would request all the delegates to post their questions in the Q&A box instead of the chat box, and also announce that the telecasting platform will be redirected to YouTube live streaming once we cross the maximum capacity. Firstly, we have a panel discussion on antenatal diagnosis of urinary tract anomalies by 4 eminent speakers. Dr. Suresh Sheshadri, he's a Director, Mediscan Systems, Chennai. Also the Honorary Secretary, Voluntary Health Services, Visiting Professor in Perinatology, SRMC, Chennai, and PSG Hospital, Coimbatore. He's a fetal medicine specialist with over 39 years experience in ultrasound, conferred FRCOG by the Royal College London. He's an ISUOG ambassador to India. His main areas of interest are prenatal diagnosis, fetal therapy, and ultrasound education. The next speaker is Dr. Divesh Desai. Sorry. Yeah. Dr. Devesh Y. Desai, he's currently the pediatric urologist and director, Urodynamics Unit, Great Ormond Street Hospital for Children and University College London. He's also honorary lecturer at Institute of Child Health London. He's completed his MBBS from Topiwala National Medical College, Mumbai, and has completed MS General Surgery from the same institute, MCH from Mumbai Hospital Institute of Medical Science. He's also the fellow of European Academy of Pediatric Urology. Next speaker, we have Dr. Balamurgan. He's a senior consultant, pediatric surgeon and urologist from Dr. Mehta Children's Hospital and Apollo Children's Hospital, Chennai. He's been trained by two prestigious institutes in India, JIPMER and AIMS. His specific areas of interest are minimal access surgery, neonatal surgery, and DSTs. The next speaker is Dr. Sudha Ekambaram. She is the Deputy Head and Senior Consultant Pediatric Nephrologist, Mehta Multi-Speciality Hospital, Chennai. She's established the ISN SRC program with Queensland Children's Hospital, Brisbane, with Mehta Institute, and also organizing secretary of National Pediatric Nephrology Conference, NEFCIS. She's organized, she's a winner of World Kidney Day 2017 by IPNA. She is a website committee member of ISPN, past executive committee member of ISPN and Nephrology Association of Tamil Nadu and Puducherry. She's published over 23 articles in national and international journals and has authored over 8 chapters in textbook. Over to the panelist.
Share my screen now.
Dr. Suresh, you can now share your slides.
Yeah. Good evening to all. First of all, thank you very much for asking me to be on this panel. And we have a very distinguished group of panelists where we are going to explore the possibilities of prenatal detection and management of fetal renal abnormalities. Because the time is very short, we are going to take a few specific cases and try to
Suresh,
discuss.
Sir?
Yes, yes.
Sir, can you please unmute yourself?
Unmuted.
He's unmuted. We can hear him, Pooja.
Yeah. Unmuted.
We can hear him. Sir, we can hear you, sir.
Yeah. Okay. So without wasting time, let's move ahead. I would like to say, being a fetal medicine specialist, there are challenges which we face in routine everyday practice. Is first of all, is our diagnosis right? Somebody says it's a multicystic kidney, another person says it's a hydronephrosis. Ultimately, the decision depends on an accurate diagnosis. The next question, should we do additional testing? Should we do genetic testing? Should we do karyotyping, anything else like that? And will there be additional problems not detected? This is the biggest problem parents face, that I tell them there is hydronephrosis and the baby is born, it also has a hemivertebra, and the whole thing is a sort of a Vactal anomaly or something like that at the end of the day. So this means how far should the counseling go, immediate versus long-term outcome? There are two types of counseling here. One counseling is what we would like the pediatric nephrologist or the pediatric urologist to give us, telling us that what about the long-term function for each kidneys. On the other side, we have the issue of about immediate issues at the time of birth and other comorbidities that could exist. So the biggest question we are still unable to answer, or we have to have a sort of a very different relationship, is who should reveal the information to the patient. Because often what happens, the first person who reveals the information to the patient imprints that in memory, and then they are unable to change their thought process when other counselings are given. So the first counseling has to be the right counseling, and that's the most important thing. So that's why we evolved this multidisciplinary antenatal diagnosis and management concept, where if any prenatal intervention is to be done for a particular organ or organ system, it is always better to involve that particular neonatal team to be part of this in the antenatal period, so that the informed decisions can be taken. So I'd like to go to the panel now and ask this question. What is the most common anomaly related to the urinary tract you see at birth? Because many anomalies are diagnosed and patient babies are terminated. So they don't see the light of the day. So when it comes to at birth, that is one question. Then how often is this information known to the parents prior to birth? And do parents seek your advice during the antenatal period? So I think these are three questions that need to be answered. Who would like to start? Sudha, you'd like to start?
Yes, sir.
Yeah.
So the most common anomaly is the antenatal hydronephrosis, which we come across. And the most common of that is the transient antenatal hydronephrosis. So that is the most common anomaly we see. And this information to the parents, first of all, it depends where the ultrasound has been done. And if it is being done by the right person, then they are able to pick up most of the anomalies. And the parents are quite well informed if it is like a single kidney status or a multicystic dysplastic kidney, bilateral ureterohydronephrosis, a bladder outlet obstruction if they are suspected. These kind of things are really well informed, and parents know that they have to follow up also they have to be very stringent in following. But one thing which I come across is the antenatal hydronephrosis, when it is not very huge and when the pelvic dilatation is minimal or moderate. Sometimes the parents are advised that if the child is born and after birth, if the child passes urine really well, the dilatation will tend to normalize and it is not of concern. So this is something which the parents have been advised, and in practice I see this very often. So this is something which is of concern, and I think any antenatal hydronephrosis, even if the transient is the most common, we do not know which patient is going to have a transient hydronephrosis. So we need to advise them for a proper follow-up with the ultrasound. And
Yes.
parents, um, so, and parents do seek our advice. Again, as I said, in these kind, as a pediatric nephrologist, to us, the most common things they come across is for a single kidney status, bilateral echoic small kidneys, and a multicystic dysplastic kidneys, and at times for a bilateral ureterohydronephrosis. So these are the common conditions they come to us in the antenatal period for counseling, sir.
Dr. Divyesh, would you like to say anything different from your perspective?
No, so I think yes, unilateral hydronephrosis would be the most common abnormality detected prenatally. We have a slightly different setup here. So we have several regional centers where routine prenatal screening at 12 and 20 weeks is offered to all pregnant women. And then we have regional centers where specialist referrals are directed. So I go across to University College London Hospital, which has a fetal medicine unit. And once a month, we will specifically screen fetuses with abnormalities relating to the urinary tract. And the team consists of fetal medicine specialists, me as a pediatric urologist, we have a pediatric nephrologist, and then those sort of referrals would generally be the more relevant degrees of abnormality. So the less severe forms will probably be handled at the local centers, and then where the condition is deemed to require further specialist input gets referred in to us, and then appropriate counseling depending on what the underlying condition is. So in fact, part of our role in that team is to provide the antenatal counseling.
Yes.
In that clinic.
Yes, this is what we are dreaming of here will happen, because I think involving the specialist in the antenatal counseling of women is the sugar. Each one is in a different location, coming together. We've been trying to see whether an online counseling can actually be organized at a given time where everybody is available from their own location. This pandemic has taught us how to do telemedicine in a much better fashion. So hopefully that will happen. So let me go on now to the next issue, which is a typical ultrasound report will contain any of these parameters. There is some dilatation there. Some people will call it as hydronephrosis. Some people call it as pelviectasis or piloectasis or hydroureteronephrosis, ureteric fullness or prominence, pelvic fullness. These are reports which we see on the ultrasound. Now, do you think is there a standardized way in which we can do the reporting, which both the urologist will understand and the gynecologist will also understand, because it's meant for both of them, isn't it? And what would you prefer? Because the terminology which you would like to use postnatally will be better the similar terminology that's used antenatally. So, yeah. Anyone? Dr. Balamurugan, are you there? Or is Dr. Balamurugan there? Sir, you must unmute your mic. You must unmute your mic.
Hear me now, sir?
Yes, sir.
Yes, sir. We do see these varied nomenclatures being used to describe urinary tract dilatation. At least the last decade, what we have seen is there's little more uniformity than trying to use fancy terms. People are trying to describe the anatomy, which makes it easier for us to objectively understand what is the problem and also to follow up these patients either on subsequent scans and on postnatal scans. During my residency, we used to give a lot of importance to SFU grading. But now we are trying to move towards the UTD classification system, which is more objective and it's easily replicable and then easy to understand and comprehend when we try to see what happened antenatally and what happened postnatally. Surprisingly, when I came back to Chennai from Delhi, I found that SFU was not very popular, except from when it came from your center, when you used to objectively mention SFU grading. I tried to inculcate that amongst the radiologists, but somehow they're not very comfortable. Maybe that's something which need to work with the radiologists so that there's some uniformity in describing what they
Yes.
see, especially on the antenatal scans, and then carrying it on to the postnatal scans as well. So instead
So
of just
I think, yes, sir.
yes,
So I think this is one of the one of the very nice papers which came out in Journal of Pediatric Urology, where it's a multidisciplinary consensus, and urinary tract dilatation is the terminology which we use. A1 and A2, A3 are combined together. The antenatal criteria which we use, one is anteroposterior dilatation of the renal pelvis diameter, extent of the calyceal dilatation, parenchymal abnormalities, if any echogenic parenchyma or cyst, and bladder or ureteral abnormalities, and also amniotic fluid volume. Of course, we always like to report on associated abnormalities like vertebral, aneurysmal, cardiac, and others. So, so can you take us, sir, when somebody gives you a report of UTD A2 or A3, then what would you tell that patient? What is the reason for this classification? Dr. Digesh?
So again, unfortunately, I'm going to slightly differ because as a pediatric urologist, whether I see anybody antenatally or I see them postnatally, I like to look at the scans myself. So we are fortunate in that regard that we are actually present. So the system works in the way the patient comes in, they get scanned, even though they may have been scanned 2 days before and then referred to the specialist clinic. We will look at the scans along with the fetal medicine specialist and then, interpret it jointly before we would then speak to the patient. So I think it's always a little bit, I suppose that's the way I've been trained, that I need to look at the pictures myself and I would
Agreed.
not rely completely on a
That
report.
this is what has happened in fetal cardiac imaging. The pediatric cardiologist always comes. We have a joint session, and then we image together, and then the counseling takes place, which is much more effective. But logistically, this is a nightmare because today I've seen 3 patients with urinary tract dilatation. Where will I go and get a pediatric urologist for that time? One person comes at 11 o'clock in the morning, another person comes at 3 o'clock in the afternoon. So,
I understand. So
yes,
to answer your question, depending on the stage of gestation, clearly if it is falling in the A2 or A3 category, the first thing we would say is if it is unilateral, so opposite kidney completely normal, you need a subsequent scan in 4 weeks time to see what is the trend. So on a single scan, it is very difficult to prognosticate or counsel. So assuming that the family is keen to carry on with the pregnancy, then you repeat a scan in 4 weeks' time, see what that shows, and based on that, you may be able to begin to prognosticate about what is likely in the postnatal period.
Yes. So I think it's a very, very important point which you brought out was the fact that we need to do serial scans to know any dilatation which is progressive. We know that there is definite obstruction somewhere. Because some of the dilatations can remain as they are, some suddenly can become very big. So that the dynamics are very different from patient to patient. So that's what it is. Now, Sudha, can you just give your own comments from looking at the local scenario here about yes, your response.
So looking at the UTD dilatation, the UTD classification, when we see it as A1, then usually we consider it to be a very low risk. So we tend to repeat the ultrasound around 32 weeks or so, and then follow them up. But if it is A2 or A3, depending whether it is unilateral or bilateral, we need to take a call, because if it's a bladder outlet obstruction, then we need to be more careful in following them up. So whether that 4 to 6 weeks is going to hold good or not, we are not sure. It depends on the LICA volume and the overall outcome. So, but on a general note, it is usually at 4 to 6 weeks, but it has to change case based, and especially if we are thinking about PUV and low LICAs less, then we need to be a little more quicker in acting. And this also helps us, this classification also helps us in afterbirth. So even in the postnatal thing, we will be able to follow them up. But as Dr. Balamurugan said, our radiologists are still yet to get tuned to this classification in the postnatal period. So that is still, I think it's a little far
Because
away.
what we found was after we incorporated this classification into our system, we found it was much more easier to talk to the patient and tell them in very simple terms where they stand. We know that A2, A3 means there's a higher possibility of some intervention. A1 has got a lower possibility of intervention. This alone, we cannot be definite about anything. But at that point, we can give this information. So let's move on to the cases. This case was she's a hypothyroid. She came for second opinion, 22 weeks. She came for second opinion for left. She came for left renal
Dr.
cyst.
Suresh, very sorry to interrupt. Can you just please increase your volume? There's been many requests that your voice is not heard very well. So if you can just increase your volume
I will,
or just
my
speak a
mic
bit
is full.
louder, that's enough.
Okay, 1 minute. My mic is full actually. I'll try to see.
I think
Yeah, 1 second. I will just 1 second. I hope it's better now. Is it better?
Yes, better. Yeah, this is better. This is better. Thank you. Thank you very much.
So, okay. So here is the patient who came for a second opinion for left renal cyst and MCDK. So the left kidney looks like a large dilatation. This is the right kidney which was there. So Divyesh sir, what would you say for this case?
Certainly on the images that are that I am able to look at, I would not label this as an MCDK, purely because if people are considering these to be individual cysts, then they are communicating, and therefore by definition this is not an MCDK.
Yes.
This is very likely to be a hydronephrosis, quite a significant degree of hydronephrosis.
Yes.
Would be my impression based on these pictures that I can see in front of me.
Yes. So this is what we also said. We said it looks like a unilateral hydronephrosis, and then so when would you like to repeat the scan? She's 22 weeks now.
So
when would you?
Yeah. I mean, I think as far as I am concerned, in the unilateral hydronephrosis, there is pretty much, in my experience, no place in at least the way we see it here. If the opposite kidney is completely normal with normal lico volume, then intervention is not something that we will be considering. So the question only is one of monitoring it through pregnancy, and then depending on the severity of the dilatation, the postnatal management and early intervention is the planning that should take place as part of the antenatal care.
Yes. My other panelists, do they agree with
So
this?
I would repeat it. Sorry, to answer your question, repeat it in 4 weeks, because that's what, the system that works for us.
System, yes. Correct. So, other panelists, do you agree with this? Similar?
Yes, sir. Yes, sir.
Okay. So this is where the caveat comes. After 4 weeks, she's going to be 26 weeks. I'm not going to do anything to the pregnancy. There's not going to be any intervention because the other kidney is working fine. I'm not going to do it. So the argument is, why can't we just go for a growth scan and see what is there? But the anxiety which is around everybody, including the patient, they says, I want to know what happened. So please come and do a scan, even though we are not going to do any intervention at that time. So at 26 weeks, as you rightly said, this patient was brought back, and this was the picture. So we thought the bladder was a little bit distended, but still the right kidney was very minimal. There was hardly anything worthwhile to call dilatation. The left kidney was quite dilated, and there was also the ureter which was dilated. So let's move further. Do you need any other information now from here? Do you think this condition has progressed? And should we be looking for any renal function or any intervention now? Sudha?
So the first thing I would like to know, because like bilateral involvement is there, what is happening to the LICA? So,
Okay.
so LICA,
Yeah. So
and
LICA is normal. LICA is normal.
LICA is normal. And the normal side kidney, whether the echogenicity is normal, the parenchymal as such, except for the minimal dilatation, everything else is normal.
Now normal. Yes, agreed. Normal. That's my information.
Since everything is normal, I would monitor this child, but definitely the condition has progressed because the other kidney is also involved now, which was not there earlier, and the bladder also seems to be slightly distant. So in this,
So any clue on the site of obstruction?
I would
Any clue on the site?
I would think whether this could be a PUV. I would just keep it in my mind, sir. But though we do not have the final
Even though the other side is not dilated fully.
yes, sir. Yes, sir. And still
Okay. Right. Now she comes at 32 weeks, and this is the picture. She comes at 32 weeks, and this is the picture. So, Divesh sir.
So this would be actually in keeping with a lot of situations with posterior valves, where at 20 weeks or 22 weeks you may have either mild dilatation or unilateral dilatation, which will subsequently progress. Now, the important thing, I think, with regards to the bladder comment that was made on the earlier scan, I think it is really important to rescan, in a half an hour or in an hour to see, does that bladder empty to completion or not? Because those are the early indicators where you will be starting to suspect that this may be an evolving picture. Now, clearly in this situation, at 32 weeks, it has evolved. Third trimester, there's increased urine production, and therefore this is what one would typically see in a child with possible posterior urethral valves, who does not have a very severe involvement that would have been very apparent at 20 weeks or sometimes even earlier. Sometimes even at 16 or 18 weeks, you can see small dysplastic kidneys, thick-walled bladder, megacystis. So, but yes, that is what I would be now considering as a likely.
I think you brought out a very important point, that the bladder emptying and filling must be seen. That's what we routinely do. With the emptying cycle is about half an hour or so. So we see the patient 2-3 times, keep measuring the bladder, because we do not know at what time the bladder will empty or whatever it is. So that's very important. Now let me go on to Dr. Balamurugan. Sir, she's 32 weeks. She has come to you with this picture, and the parent is asking, sir, you say that there is obstruction to the passage of urine. So why not I just deliver the baby now and then so that you can relieve the obstruction, or some form of antenatal intervention can we do now to relieve the obstruction?
Yes, sir. If this patient presents to me with this picture where there is a bilateral hydroureteronephrosis, a distended bladder with a normal looking renal cortices and amniotic fluid, I will explain to them the situation, say this possibly or probably an outlet obstruction of the bladder, but not significant enough to produce severe affection of the kidneys. So
Yes.
we can safely continue the pregnancy to term and then try to manage this postnatally, because there is no impending threat to the lung growth because the amniotic fluid is pretty good. And there is no necessity for us to do any intervention inside. Not that fetal intervention is not without risk. We will do that only in select cases, and this baby does not warrant. And baby has already reached 32 weeks. Even if there is a threat of oligohydramnios, this baby can be safely brought out and then managed postnatally, which is much more easier and simpler to manage than doing a fetal intervention.
So you are pushing for a higher gestational age at birth.
If the amniotic fluid is normal, we can safely wait on this patient.
Okay, sir. So the Leica was quite normal at that time. So now we have changed the diagnosis. Now everybody is saying it probably could be post-uteral valve. And yes, this is the time the pediatric surgeon consultant will give us the information. Now she comes at 36 weeks. And 36 weeks, this is the picture. You can see the bladder looks highly trabeculated. And there is oligohydramnios. So now plan of action. Divyesh sir, what will you do?
Yep. What's the Leica status? Sorry, oligo.
Yes, sir. Now it's the Leica has become oligo. It has the deepest pool. I mean the AFI is about 5.
Okay.
Lower limit.
So
Lower limit.
AFI of 5 at 36 weeks gestation. Again, at this stage, doing something in terms of either inducing labor or delivering early and taking it to term, I don't think there is going to be any significant change in outcome. What we need to ensure is that when the mother goes into labor, that there is appropriate arrangements made for that child to have the necessary pediatric urology bed and consultant available, so that the treatment can start soon after delivery.
So anyone worried about lung hypoplasia with this reduced Leica?
Not at 36
it's at
weeks.
36 weeks. Up until 32 weeks, my understanding was that the Leica was normal. If
Yes.
Leica is normal up to 32 weeks, the risk of lung hypoplasia is minimal.
So where do you want this baby to deliver? Should it be delivered in a tertiary care unit, or they can deliver anywhere the baby can be transported? Is it going to be such an acute emergency at birth?
No, it's unlikely to be an acute emergency. They can be delivered and then arrangements made to transfer to a place where there is the appropriate care available.
Sir, sir, Dr. Balamurugan, sir, immediate postnatal management. Do you, is the pediatrician going to take care first, or you're going to come in straight?
No, we like to come in and see the baby once the baby is born. I'll clinically examine the baby to see if I can feel the bladder, distended bladder, and feel if the kidneys are distended. With a suspicion of bladder outlet obstruction antenatally, we like to do an ultrasound on day 1 to see what is the status of the kidneys, ureters, and bladder, and take it forward. And also, while looking at the bladder, I'll also try to look at the posterior ureter to see if it is roomy and dilated, which pushes us more towards the possibility of posterior ureteral valve. With ultrasound imaging suggestive of a posterior ureteral valve, I would do a baseline renal functions after 24 hours, and then plan to do a micturating hysterogram to document the presence of valve and also to see the effects of the posterior ureteral valve on the bladder, ureter, and the kidneys, and then take it forward. So
you are not in a hurry. You are not in a hurry to do the fulguration.
No, I will do a clinical examination first, do an ultrasound on day 1, and then
what is the time difference? What is the time difference for all this? From birth to when? When should the thing happen?
Clinical examination is immediate, sir. Ultrasound will be on day 0 of life. Then MCU, if the baby is stable, I'll do the renal function test after 24 hours so that it reflects on the fetal status. I will do a bedside mixed-rating cystourethrogram myself, or this can be done on table if the findings are very strongly suggestive of post-urethral valve. Otherwise, I like to do the mixed-rating cystourethrogram myself under aseptic precautions on day 2, day 3, and then take it forward. If the baby's weight is good enough, we can take up for primary fulguration or incision of the valve.
So this was the final picture. You can see the dilated posterior urethra. This is the 3D antenatal 3D picture with the dilated posterior urethra, and so the reduced lichen. She was delivered by LSCS at 37 weeks. Just as I said, there was no hurry to deliver the baby. 2.7 kg, small stream of urine passed at 6 hours. Postnatal diagnosis was post-urethral valve. So you will answer this question of timing of postnatal intervention. Now the parents want to know about prognosis for this long term. Now you have set right the problem.
Dr.
How?
Suresh, in
Yes.
time, we are almost at the finish time for this panel discussion. If you could just take up one more case that you have, I think with the next one very quickly. And Dr. Balamurgan, I think you have some problem with your speaker. There's so much background noise. If you can just in the meantime quickly do something about it. Thank you very much. Thank you all the delegates for the audience.
Okay. Okay, one minute. Okay, so this patient came to us at 22 weeks. Okay, and 22 weeks, everything seemed to be normal. And she came at 28 weeks. This was the picture. There was unilateral hydronephrosis. But when you look at this kidney, it was looking very different. It was not uniform hydronephrosis, but the lower part of the kidney was showing dilatation. The upper part was not showing dilatation. Now, any ideas from here?
Possibly a duplex, sir?
Yes, looks like we also thought it was a duplex kidney. So we went down and at 28 same thing, and at then we found this in the bladder. So we found bilateral large erythroceles in the bladder. So now can you quickly tell us about how do you manage antenatally? Is there any role for managing bilateral erythroceles? Are they going to cause any problem, or okay, they can be left alone? So, yeah. Divya sir, what would you do?
No antenatal intervention. We would deliver the baby at term and carry out our routine investigations. So catheterize the baby, we would get an ultrasound scan, we would get a mixed-rating cystourethrogram, and depending on the function in individual moieties, then plan on definitive treatment.
So do these have the same effect on the kidneys as opposed to urethral valve? As far as obstruction is concerned?
No.
So these babies do better?
The presence of a erythrocele, it is very unusual. If you take the whole spectrum of duplex kidneys, for a erythrocele to cause bladder outflow obstruction is very unusual. It can happen, but that's not a common presentation. So what is more common is that you have erythroceles with varying degrees of affection of the upper tract. In some, you can have a non-functioning upper moiety. In some, you may have a salvageable function in the upper moiety. So intervening on that erythrocele, the question is of what is the most definitive way of treating something postnatally. Because if you start with puncturing erythroceles, you can actually find yourself eventually ending up doing both upper tract and lower tract surgery, which is not ideal.
Yeah. So when we went through the literature, there's some prenatal therapy which has been proposed, like ultrasound guided percutaneous drainage, laser fulguration, and fetoscopic in utero incision of the erythrocele. A few cases have been done where they've had in the second trimester large erythroceles obstructing the kidneys. So this is one such case which came very early, and that is the fetal cystoscopic view of the erythrocele, which was punctured. But ultimately, when the baby was born, the kidneys were quite dysplastic, and it did not do really well at all. So that was the outcome for that case. So I think if time is up, I think we will we will stop here because I don't think we have time to discuss shunting. Sukanya?
In the interest of time, yeah, very thank you for that, sir. We can just take a couple of questions
Yes.
here, which the audience have
Yes.
posted. Any
Yes.
one of you can answer. One is, it's a question one, why antenatal hydronephrosis is common in the right side? Would any of you want to take it? Is there any specific reason for that?
Antenatal hydronephrosis is more commoner on the left side than the right side in what we can see. And I don't have any answers for that aspect.
I completely agree. My understanding is it's for some reason more prevalent on the left, but nobody has any idea as to the laterality prevalence, what the reason is.
It's a good question. We've also seen more on the left side than right side during our antenatal scans.
The next question is from one of the attendees. So how early you can do a DMSA scan?
Usually the DMSA scan can be done at 100 days of life. So that is where we get the cortical maturity. 100 days of life is the earliest time where you can do a DMSA scan.
The panelists would want to add to that.
So in a term baby, if urgent intervention is being planned, we can get a reasonable DMSA scan to make that call on function at 6 weeks.
Okay.
Safest is for 6 weeks, but the advantage of, if you're looking at an obstructive evaluation for neonatal hydronephrosis, if you're looking at MAC3 versus LAEC, that can be done a little earlier by 2 to 3 weeks. That's the advantage of MAC3 over DTPA or LAEC. But DMSA, I think the earliest we can do is 6 weeks.
That's all the questions we have. So in case any of the attendees have some more questions, you can still post it here. If there is time at the end of the urology section, we might take it up once more. I request all the panelists to stay back for that. Now I'll hand over again to Pooja so we can go, of course, to the remaining topic.
We now move on to the next session, which is on fetal renal interventions. And this session is being chaired by Dr. Abraham Cherian. He's a honorary consultant at the University College London and a consultant pediatric nephrologist, urologist at the Great Ormond Street Hospital. He's a visiting surgeon to various hospitals in the country. He's also an overseas visiting surgeon to Istanbul, Ukraine, and Belgium. He's a honorary secretary for BAPS and also the course director for the BAPS Shorts Advanced Lab Urology course. He's an examiner for the FRC Pediatric Surgery Examination and is a National Training Program Director of Pediatric Urology Fellowships in UK, and currently the Program Director of the European Pediatric Urology Fellowship at GOSH. He has set up the Cloacal Malformation Multidisciplinary Service at GOSH and is currently the joint lead. He's been associated with various societies, and he is currently the president of the British Association of Pediatric Urologic Endoscopic Surgeons. Speaking in this session, we have Dr. V. Shripati. He's a senior consultant pediatric urologist and robotic surgeon, also the director fellowship program at Apollo Children's Hospital, Chennai. He's an adjunct professor at the Tamil Nadu Dr. MGR Medical University. He's a past president of the Indian Association of Pediatric Surgeons. He's a part of the Crick-Beck consensus to standardize the management of the anorectal malformations in children. He's also the president of Indian Association of Pediatric Surgeons. He's completed around 276 robotic surgeries and has delivered 7 named orations, over 65 publications. He's conducted the first pediatric robotic workshop in India at Chennai. He's been in charge of the 2 conjoined twin separation at Apollo Hospital, Chennai, and has conducted grand rounds and teaching rounds across the globe in various countries. Over to you, sir.
Can I start sharing now?
Yeah. Yes, sir.
Yeah, okay. So it is indeed a pleasure. Thank you. Thank you for this opportunity, Dr. Suganya. It's a very prestigious meeting. And to have somebody of the eminence of Abraham Cherian chairing the session is a feather in the cap. So the topic is fetal renal interventions. I, of course, requested Dr. Suresh to give this talk because he's the better guy to do it. But for some reason, he was not, he refused it. So I'm doing it on his behalf. So what we basically have is all the data that is presented in this paper is the work of Mediscan Systems and Dr. Suresh and his team. There is no doubt that Suresh is the pioneer in fetal ultrasound and intervention in this country. And I thank him for permission to use his institute's experience in this presentation. So the preliminaries, as has already been said, I think Balamurugan said that any form of fetal intervention is risky. The key elements are careful patient selection and optimal timing. And the most important point, which I think Suresh has brought out very well, is that it should be a collective decision. Therefore, careful parental counseling is very important. So the first point, again, Suresh spoke about this. Are we absolutely sure of the diagnosis? Please remember, there are about 23% false positives. For instance, I've seen in the best of institutes at the Royal Children's in Australia, we had a problem there differentiating between PUV, urethral atresia, and prune belly syndrome. And sometimes it can be very embarrassing if that comes out. And remember, any one disease can present with varying degrees of renal dysplasia. Nowhere is this more valid than in PUV. Therefore, intervention may not be useful in all. And of course, fetal urinary biomarkers are very useful. So the clinical score for an antenatal diagnosis of LUTO, this has already been brought out very well by Dr. Suresh. Essentially, you have a big bladder. Please remember this volume because we'll come back to this a little later. The diameters will be of the ureters will be big. There will either be oligo or anhydramnios, the fetal sex male and a referral before 28th week. And if you give a score to it, then that once you get a combined score, you can decide whether this falls into the category of LUTO. If you want to know which is an optimal intervention window, these are some of the questions that I ask in my mind before I talk to the parents. The first is, if I intervene at this particular stage, will restoration of amniotic fluid volume reverse the effect of the LUTO? Second, will it avoid ventilation at birth? Obviously, this point has again been brought out in the previous discussion. It has to be fairly early to be able to do that. Will it create reasonable renal chemistry if I do a risky antenatal intervention? Or at least will it completely avoid the need for the renal replacement therapy? Or in the very least, can the need for renal replacement therapy be postponed to the second decade? And these are all the questions that we try to answer in our counseling session. And obviously, sometimes it cannot be done in one counseling session. You might have to have repeated sessions with them. And the most important thing is to be so receptive to them, to tell them you can always come back later on and talk to us again about any doubts you might have. So the staging system proposed by Ruano et al. Is perhaps the one that is most useful. Essentially, what we want to do when we intervene in LUTO is a stage 2, where the kidneys are good, the fetal renal urinary biochemistry in repeated samplings is quite good, and therefore your fetal intervention will prevent both pulmonary hypoplasia and also prevent severe renal impairment. What we don't want is a stage 4, where the kidneys are already shot to pieces, the fetal urinary biochemistry is bad, and obviously, whatever intervention you do will only prolong the life of the child, but may not be useful from both the renal and the pulmonary point of view. Oftentimes, what we are faced, especially in India, because they come a little late, is some sort of renal damage, a not very favorable urinary biochemistry. And at this particular time, we do a fetal renal intervention, not because we want to prevent a postnatal renal impairment, but to sort of push it back a little bit, but more importantly, it is to prevent pulmonary hypoplasia. So since 2010, the total number of cases that Mediscan has done, the total lower urinary tract obstruction was 385 cases, the majority of which have been in the second trimester, as you can see. So fetal urinary sampling from 2036 cases have been done for lower urinary tract obstruction. In 12 cases, this is where we come in. It was for oligohydramnios, and the biochemistry, the fetal urine analysis was always abnormal, particularly a beta-2 macroglobulin of more than 6. In these cases where the liquor is present and is within the normal range and the urinary biochemistry is all right, as was discussed before, we sort of wait for the delivery to happen and take it up later. Now, 7 children have undergone a Harrison double pigtail shunt. All the cases had decreasing liquor. In one child, we have a 16-year follow-up. In one case, we have a 5-year follow-up. 2 shunts got dislodged, were not repositioned. 3 children were lost to follow-up. So here you have a picture here on the top screen where the video is being played. The Harrison's double pigtail shunt is being handled by Suresh, and he's going to thread it onto a needle. This is the needle that will puncture the fetal urinary bladder. In order to shift the shunt into the bladder, you have that yellow, pusher which is going to be threaded on top of that. So this will slide the shunt off the needle into the bladder. And you can see already the bladder has been tapped. The needle is inside the fetal urinary bladder. And you can see a simultaneous video playing down here. And the pusher is being used to shift the shunt, to push the shunt into the bladder, and thus completing the procedure. One loop of the shunt will be within the bladder, one loop will be in the amniotic cavity, thereby making it a vesico-amniotic shunt. And you can see the position is being confirmed and the increase in amniotic fluid is also being confirmed. And this is at delivery, this is the way you see it. I want to point out something that's very important. You can see the shunt is flat on the abdomen because a shunt that projects out, the fetus has every chance of pulling it out. So it's a flat shunt which is on the abdominal wall. And you can see a picture here where you can see the bladder has collapsed. This was the distended bladder, a collapsed bladder with the shunt in the amniotic cavity. So at 16 years, this child has a creatinine of 1.1 and has minimal BUR and is doing well. But we also had one complication. The story is very interesting. This was a 38-year-old primary post-IVF pregnancy. We confirmed an LUTO at a PUV at 25 weeks. At 26 weeks, there was hydroureteronephrosis with grossly distended bladder. If you remember, 35 centimeter cubed was the volume that we spoke of before. This was more than 10 times bigger. At 28 weeks, a percutaneous ultrasound-guided vesicoamniotic shunt was put in. Post-shunt, 1 week later, there was good decompression of the urinary system and a marginal decrease in the beta-2 microglobulin. But at 30 weeks, the child developed urinary ascites. The shunt had slipped from the amniotic cavity into the peritoneal cavity of the fetus, primarily because I think it was a huge bladder, and when it decompressed, it pulled the shunt into the fetal abdominal cavity. Suresh had to tap about 150 mils of fluid. DEXA was started for lung maturation. At 32 weeks, LSCS was done. Immediately after birth, another 350 mils was tapped. The baby was ventilated and catheterized. So here is at day 2 of life, we drained the ascites. We did a scopy with a 6-7.5 scope and then used a 3 French tipless nitinol basket. You can see the video here of the shunt being snared and taken out. But before doing this, there were several things that we did. We did dry runs to see if the shunt could be removed within a small orifice and whether the shunt could be straightened with ease for it to come out. Before we did anything to the shunt, we had to incise the PUV at the 12 o'clock position with the diathermy and then enter the bladder. Something very interesting happened when this case was being done. We did put a small needle here to drain the ascites because we knew that when we put fluid inside to do the PUV fulguration and take out the shunt, the fluid would go into the abdominal cavity. This needle couldn't cope with the volume of fluid that came in, and the child had splinting of the diaphragm, and we had to stop the procedure and do a drain and then proceed, and we removed the drain 2 days later. At 5 years of age, the serum creatinine for this child is 1.4. In Texas Children's Hospital, using the Runauer criteria, 14 children have undergone vesicoamniotic shunting in stage 2 LUTO between 18 and 30 weeks of age, and 86% have survived. 67% have normal renal function, and these are the 6-month survival figures. Fetal cystoscopy, as Dr. Suresh has said, is the new paradigm of management. So now we offer either the option of vesicoamniotic shunting or fetal cystoscopy in LUTO with oligohydramnios with disordered urinary indices where early delivery is not an option. And the procedure we have done is a laser fenestration of 2 posterior urethral valves and 1 fetus with bilateral urethral. This was Mrs. B, who mother with a bad obstetric history, 1 spontaneous abortion, 1 child with biliary atresia who died at 8 months of age. At 21 weeks, she was diagnosed to have a PUE. You can see the keyhole sign very clearly there and a very thick bladder. At 27 weeks, she had a huge posterior urethral dilatation. The parents opted for an in utero fulguration, which we did. The second lady presented at 29 weeks for bilateral ureterohydronephrosis, and there was a rapid reduction of AFI from 12 to 8.8 to 6.9. At 29 weeks, 5 days, antenatal fulguration of the PUE was done. You can see the picture here again, the pigtail, the keyhole sign, and a dilated posterior urethra showing the PUE. So the technique is the OT is set up in an obstetrics gynec unit. The mother is awake, local infiltration is given, the anesthetist is on standby. The fetus is immobilized by pancuronium given in the deltoid. A per abdomen fetal bladder is punctured with a trocar and a 1 millimeter scope, 0 degree is introduced. It's a curved fetoscope and is directed into the posterior urethra. A 400 nanometer diode laser fiber is introduced and contact fenestration is done at a low energy setting. A simultaneous 4D ultrasound of the fetus and a camera visualization are set up. The baby's heartbeat is audible to all, especially to the mother. The mother is constantly engaged in conversation. Once puncture is done, fetal voiding can be seen, the kidneys decompress and the amniotic fluid volume increase. So here's the setup. Here is the obstetrician, Dr. Uma. This is Suresh with his back to us. This is Dr. Sudarshan. Here is the 4D ultrasound that's been set up. Here is the camera, the fetoscope camera, and here is the recording device. So essentially, anybody who wants to do fetal intervention should be very good in both modalities, not only in the ultrasound visualization of the fetus and its complex anatomy, but also have the ability to navigate within small spaces with a small scope. So you can see the procedure in progress. What I wanted to show you was this particular picture, which I took out from a journal article. You can see the fetoscope has gone through the bladder, has avoided the placenta, the cord. You can see the baby's legs are flexed. So you have a very small window through which you pass the fetoscope into the bladder. Literally, the baby is skewered on the fetoscope. And I want you to imagine that here is a baby that cannot be moved, that's paralyzed, and you have a fetoscope that's going inside. So the chances of something going wrong are very high. So here is an in utero fenestration of the laser fenestration of the posterior urethral valve. You can see here that's the bladder neck. We are doing an antenatal fulguration, and this is where we come in. I'm here to provide help to say where to fulgurate. There's a reason also as to why he's kept me as hired help. I'll show you why. So here we are. Here is the laser fiber coming in. We tell him that this is an optimal place to fulgurate, and he does. Now, the fetoscope can be introduced through the posterior urethra into the posterior urethra, but it can't be bent too much because the baby is literally hanging off it. So we have to make a considered decision as to what would be an optimal position or a place to do it. So what we do is we do multiple holes and try and join all of them together. And as you do it, you can see that once you finish it, you can see the voiding through the urethra and the amniotic fluid volume picking up. Just to show those all the senior members in the audience that we haven't made any mistake, and as we are coming out, you can see the verumontanum, which is completely all right. And our job as the pediatric urologist is to guide Suresh as he is doing the fulguration. There is the verumontanum. And then we come out into the bladder and the procedure is done. Now, though we had done this, at 31 weeks, the bladder was normal, filling and emptying was seen, the liquor was normal, the baby was delivered at 36 weeks. We did a postnatal fulguration on day 3. Now, this is what I thought was important. When I went in, I was very curious to see whether we really had done something or were we really fooling ourselves. Here is our scopy that we were doing in this baby. You can see the valve is just coming up. Here is the endoscopy. This was done with a 6-7.5 scope. And you can see that is the hole that you see there. This is where we had actually done the in utero fulguration from the other side, from the bladder side. Seeing this convinced me that we really had done something worthwhile. And then I completed the fulguration at the 12 o'clock position for this baby and finished the procedure. Now, for all those who are listening to this, we did a redo fulguration at 6 months. Please remember the 3 and the 5 o'clock, the 5 and the 7 o'clock positions also need to be done. This was 11 months old at some time before. The child was voiding well, no post-void residue, with a creatinine of 0.5 and a slightly elevated spot protein creatinine ratio. We have subsequently, due to COVID, have lost follow-up in this child, but I understand that the child is doing well. This is a child that Suresh spoke to you about, an in utero laser fenestration of uretroceles, a transvesicoscopic laser fenestration of the uretroceles. You can see the uretroceles coming up. Uretroceles are as severe an obstruction as you can get in posterior urethral valves. And there is the fetal cystoscopy. I think Suresh didn't have time to show it. Again, we have entered the bladder. You can see the uretrocele there. That's the obstruction of the ureter at the lower end. And here, the contact fenestration is a little easier to understand because you're not looking at an impossible angle. And we make multiple holes and the uretrocele will collapse. And we did it on both sides. And this is the post-uretrocele decompression status. You can see the collapsed uretroceles are at the base of the bladder. You can see the bladder is a little distended, but the kidneys have decompressed quite a bit. So the outcomes of vesicoamniotic shunting and fetal cystoscopy in a 2020 systematic review of published studies of 355 fetuses undergoing either vesicoamniotic shunting or fetal cystoscopy, the perinatal survival was higher in those who had undergone shunting versus control. The postnatal renal function was definitely better in those who had undergone shunting versus control. Even when you compared fetal cystoscopy versus control, the renal function, normal renal function at 6 months follow-up was better in the fetal cystoscopy group versus the control. So there's obviously some benefit to doing this. However, the very important thing to remember is this is not something for the faint-hearted or those who are not very clear about what they are seeing. The complications are many. Here we have maternal chorioamnionitis, premature rupture of membranes, intrauterine death. You can see a shunt in the thigh closely missing the femoral artery. Fetal complications are a 54%. Please remember that. Shunt migration is one thing, but these sort of complications are horrible. I've just taken this from the latest edition of Campbell's Urology, where the bowel is coming out, and in one case, the shunt has gone around the umbilical cord. This is the feared complication of a urinoma with urethral perineal fistula. This is why Suresh wants help standing by his side, because if you make a hole in the base of the urethra, that's a sort of a fistula that's pretty hard to repair. So the recent advances are a flexible fetal cystoscope, which can negotiate the 117-degree angle between the bladder neck and the posterior urethra in LUTO. Imagine if you had a flexible fetal cystoscope, once you enter the posterior urethra and I want a better view, I can ask Suresh to move the scope up and down, and so we can decide which can be the optimal position to fulgurate the valve rather than actually imagining the place. Low pressure valve shunts are particularly useful, which will enable bladder cycling, because as you can remember in one of the cases that we showed, a sudden collapse of the bladder is not a great idea. But what I think will be a game changer is flanged shunts, which can double as vesicostomies in the postnatal life. They will have a flange both inside the bladder and outside when they open out. And subsequently, you don't have to be in a great hurry to do a cystoscopy and a fulguration in the newborn period, because this will just work as a vesicostomy and will take the child forwards. So here is the reference. This is Journal of Pediatric Urology 2021, a very comprehensive article which you can go through, which will give you an idea. So this is our experience with fetal interventions, renal interventions, and I hope it was helpful. Thank you very much.
Dr. Sripati, I really thoroughly enjoyed your talk. It's amazing to see your experience in this area. I thought you were just a pediatric urologist. But great work. There are a couple of questions that have come up, but I wanted to just kick off. Have you actually used, or do you have flexible scope?
We don't have a flexible scope. We don't have a flexible scope. I think the answer to that is able to answer that, but we don't have a flexible scope. As of now, we have just a curved scope, which looks like one of those, big dilators that we use for urethral dilatation, and that's about it. So you go into the urethra, and honestly, Abraham, we don't really know where they are. Yeah. I know we have missed the. We go beyond the crista, and I say this should be a good place, but it can well be that you're in the urethra and you're making a hole in the base of the urethra. It can
yes. And are there any clues as to reduce that margin of error? Because it's so tricky.
Yeah, the thing is,
with a straight scope.
Yeah, I think it's particularly difficult. I've had a little experience with antenatal fulguration, but antenatal fulguration, when we started it off as a small project years before, when we didn't have the scope, turned out to be a disaster later on. What I would like ideally to do is to look at the 12 o'clock position very well, like what you can do from a regular scopy, and then open it out at that particular point. In this particular case, we're just taking an educated guess, that's all.
Thank you. So there's a question on the Q&A section. Why do we get residual valves after previous intervention? Do persistent poor stream post-fulguration, is it sufficiently evaluated by an MCU? And is it advisable to err on the side of a check cystoscopy rather than stay sure on the MCU alone?
I think it's a very valid question, and the very simple reason as to why you have a residual valve is, I'm sure Divyesh, you and Bala will agree with me. In a small baby, when you're using the 7.5 scope and you're just using a Bugbee, the simplest thing you can do is you can make a hole at the 12 o'clock position, and that's about it. If you try and chase the 5 and 7 o'clock positions, you're going to end up with a lot of extended burns, which is not very good for the pediatric urethra. And the most important, so that obviously means that though you have a break at the 12 o'clock position, there are still 2 leaflets there which need to be cut comprehensively at the 5 and 7, for which you need a roomier urethra to accept the 9 French or the 10 French resectoscope. So that's the reason why you do it. Now, the practice as to whether you would rely on an MCU or whether you would go for a check cystoscopy varies from place to place. I would say, if you can, a couple of things, if you can do an ultrasound and you have a huge post-void residue, you really don't need anybody to tell you there is a residual valve. That's number one. You can go in for a check scopy. If your center is a big center and you have a very good MCU, a radiologist there who does pediatric investigations, go ahead and ask for an MCU and then take it up, because an MCU in that setting also gives you an idea of the reflux status, gives you an idea of what the bladder is like, what the bladder neck looks like. All that is useful information to have. But I think in the absence of all this, doing a regular check cystoscopy down the line at about 3 months is a very good option as well.
There's another question on the uretrocele. What was the indication for proceeding with the unilateral uretrocele or intervention in the uretrocele?
Yeah, it was actually a bilateral uretrocele, but I think Suresh has got his hand up. He's the chap who has to answer that question.
Yeah, so we were following up this patient. The Leica suddenly went down. It was bilateral uretrocele, became much larger as we saw. It was not collapsing at all, and the hydronephrosis was increasing and the Leica was reducing. So we got worried. She was remote from term, so we said we need to give some kind of this thing. Then I found in the literature there were a few cases which have been done for this particular indication.
Okay. I have another question. In India, with respect to valves and sex of the patient, how do we deal with that delicate issue about sex of the patient and diagnosis?
Yes. The moment you say posterior urethral valves, everybody knows it's a male baby, right? And that we don't need to write it on the report that it's a
Okay.
male baby. It is going to be known. Now, the PCPNDT Act expressly prevents us from, I have neither seen nor reported nor explained revealed the sex of the baby to the parents. This is all. We never talk about the sex to the parents.
Mhm.
We say there's a posturethral valve, they understand it by themselves. So we never
Right.
use the word male, female at all. But the Act also provides for any genital tract abnormalities you can actually reveal, especially genetic abnormal, like if you have a ambiguous genitalia or hypospadias, for example, which we diagnose antenatally, you are allowed to reveal the sex for those cases, as long as you have a good documentation.
Thank you very much. Dr. Sripati, I don't have any more questions on my Q&A section, but I thoroughly enjoyed your talk. Thank you so much.
Thank you, Dr. Abraham and Dr. Sripati. A wonderful, wonderful session. Thoroughly enjoyed it. The next session is going to be chaired by none other than Dr. Sripati, and he's probably, I'll leave it to sir to introduce the speakers and take it forward.
Can we have Suganya? Can we have Pooja doing us the introduction again? I thought both of them were introduced just now.
Yes.
Yeah.
So I think we can just go ahead with the session. Anyway, for all the participants, we have two doyens in pediatric urology who are driving the pediatric urology program in the UK, and it's our good fortune and our privilege that both of them are passionate about transferring or sharing their knowledge with us in this country, and we're really gifted for that. Thank you very much for both of you for consenting to be with us here today, and we really look forward to your experience. Dr. Divyesh, I think are you going first or?
Yeah, I think I'm going first. Can I share my screen now?
Yes, please.
Yeah, please.
Yes, please.
Sorry, just give me a second. Yeah, no, it's open, the PowerPoint. I don't know why it's. Can you see the?
Yes, we can see your screen, which is the Zoom screen.
Thank you. Can you see now? Can you see the?
Not the presentation yet, Divesh.
Okay, sorry, apologies.
That's all right. That's okay.
Go back.
I see you're getting some IT support.
Technical IT support.
Yes.
I think if you stop sharing your screen and then probably access your PowerPoint first and then again start sharing, I think it'll be easier.
Okay.
You should be able to see it now.
No, we
Abraham,
still.
can you see it?
No, Divesh. I'm still seeing your web browser with the URL directed to Zoom.
Maybe
That's very strange.
come back again.
It was open. No? These are some, I don't know. No, maybe in the. No. Yeah. No, that's the presentation. That's the Zoom, I think.
Divyesh, have you gone out of Zoom or what? No, I think you're still in Zoom.
I can hear you, so I should still be in Zoom.
Yeah, we can see you, so you are in Zoom. Yeah.
You have a post-attendee Zoom thing, which I think, I don't know. Maybe you have.
Abraham, do you want to go first? And I'll try and sort out at my end.
Yeah, sure. That's not a
Yeah?
problem. Yeah.
Just to save time. I'm not sure what has happened here because the presentation was open.
Would that be okay?
Your screen, yeah, that's perfectly fine. That's perfectly fine.
Okay, I'm going to share my screen then.
Yeah.
Something else. No, this is a mess.
Oh, so I can't share it when another participant.
I'm just briefly stopping Dr. Divya's share, and then
I'll
just pass to you. Yeah. So Dr. Abraham, you can share your screen now.
Sabrina, I joined it through a link. Now I can't find Zoom.
Divesh, could I request you to mute your mic? Dr. Sukanya, can you see my screen, my presentation?
Your presentation. Yes. Go ahead.
Okay. And you can hear me clearly?
Absolutely.
Okay, thank you very much. Dr. Suganya, thank you for the kind invitation. It's a pleasure and honor to be here and speaking to you about a topic that's really close to my heart and my practice. Dr. Sripati, thank you also for the kind words that you shared about us and in the UK. Going straight to the talk, you will very soon realize what the channel is about, but this is a satellite view of the English channel, which I'm not going to talk about. Everybody likes a story. And this is a true story. All the characters are true. They are not fictional. So bear in mind that in between we'll have short interjections of some context. So the story starts off again at the beginning, which is basically a couple that comes to the scanning unit. The mum-to-be is about 24 weeks pregnant and has a scan and is given some alarming news. So the baby has got bilateral hydronephrosis. They can't see a bladder, or what they see is a very small bladder, and they see a cyst in the pelvis, which is occupying most of the pelvis, and it looks septated, and it's a girl. So then they get referred to the regional center for some antenatal counseling. So the pediatric urologist is there, the nephrologist is there, and the mental unit consultant is there to counsel. They are given the possible diagnosis, which is one of them being a cloacal malformation being the top of the list. The prognosis is also discussed quite briefly, but certainly a pregnancy that can be viable. And we know that there is a team that will look after that child when the child is born. The place of birth is also discussed because it's important that the child is born into a unit that has got nephrology, intensive care, a urologist, and a pediatric surgeon, because there can be multiple anomalies that may be involved. The timing was also discussed, interventions also discussed, but one particular aspect is discussed further, in that there's quite a bit of fluid in the abdominal cavity of the fetus that is probably compromising the other organs, causing high drops, and a shunt is discussed. The parents agree to the shunt, and the shunt is placed, and the pregnancy progresses, and the child is born. So this is the baby that's born. You can see the shunt in the right upper quadrant, quite a distended abdomen. There's no anal opening. There's a slight ambiguity of the external genitalia. And there's quite a bit of respiratory distress for which the child gets intubated and ventilated. A nasogastric tube is passed in, an abdominal x-ray is done, some scans are done, and a quick examination and a brief history taken. So the antenatal history is known. So for all practical purposes, this is a cloacal malformation until proved otherwise. Just to put some context here, some words are interchangeably used by some people, namely exstrophy, cloacal malformation. These are all very different anomalies. The top picture is a bladder exstrophy in a male. The bottom picture is a cloacal exstrophy. The cloacal exstrophy is quite an uncommon condition, and it's about 1 in 250,000. The cloacal malformation, generally considered to be an anorectal malformation, is about 1 in 50,000, similar in incidence to a bladder exstrophy. So the picture on the left is that of a normal female arrangement of the urinary tract, the genital tract, and the gastrointestinal tract. The two pictures on the right is that of a cloacal malformation. There are different types, and two most common types are showed here, which is basically all the systems draining through a common channel to the outside. But the difference between the top and bottom is that one is a long common channel, the bottom one is a short common channel. Now, these are pictures, and all of them are cloacal malformations. So there is a spectrum in their phenotypes, but they all have a single opening. Except for number 5, all the openings are quite in the front or quite more anterior. Now, one of the problems, or at least perceptions of this condition, is that it's is named under the anorectal malformation category. Now, what has happened probably because of that is that there is a disproportionate focus on just the gastrointestinal tract without understanding the elements of the anomaly that causes more morbidity, which is the urinary tract and the genital tract, that can cause urinary outflow obstruction and renal dysplasia and renal failure. They are better grouped under this condition of disorders called the partial urorectal septum malformation sequence. And there are some publications in literature if you are interested. Now, an anomaly that is worth special mention here is that here the opening, at least the picture on the left, the opening looks like a normal anal orifice, but it is single. Now, this is a posterior cloaca. The orifice is pretty much almost in the sphincter muscle complex, but if you put a telescope through that, you will find anteriorly a urogenital sinus joining the intestinal tract. A variant of this is on the right, where you can actually see 2 openings. There is an attempt for both these openings to have been one, but what you can see is the posterior opening is the anal orifice and the anterior one is a urogenital sinus. But the important thing to note is also that there is no perineal body. And then you can get bizarre conditions like this, again with a single opening in the perineum. But please note on the left, you can see that I have marked the symphysis. There is a very wide diastasis. These are covered cloacal exstrophy variants. So they are cloacal exstrophies, however, they are covered. So these are actually in the more severe end of the spectrum. Coming back to cloacal malformations, up to 30% of them can have hydrocolpos, which is distension of the vagina that results in urinary outflow obstruction by having some pressure effect on the lower ureters or even at the bladder neck level. What is interesting is that urine preferentially drains into the vagina rather than to the outside world. About 40% of this anomaly has Mullerian duplication. And more than 90% of them have a variety of other systems involved, namely vertebral anomalies, cardiac, upper aerodigestive, limb anomalies, renal dysplasia, spinal dysraphism, and a host of other urinary tract anomalies. The commonest of the urinary tract anomalies, about a quarter of them are single or solitary functioning kidneys and a high incidence of reflux, which can have an ongoing impact on renal function if associated with urinary tract infections. Now, I know this is a very busy slide. This is a summary of our pathway of care for this condition. There is a team dedicated to looking after these children, and I will try, so forgive my next few slides, I will try and break this up and try to make some sense of it. Now, it's important just to see the main or the salient features which I will highlight and not go through each and every part of this pathway. So just to break it up, the top half, after they are born, the diagnosis is pretty much a clinical diagnosis. A single perineal orifice in a female is pretty much a cloacal malformation until proved otherwise. And the importance at birth is to know whether they need ventilatory support and whether they need drainage of their urinary tract. So those are the two important things. Of course, all the other associated malformations will play a role in how things are managed, but pretty much these are the most important things. So some basic investigations, blood tests, ultrasound of kidney ureter bladder, an echocardiogram, and consent is taken for diverting the stool from the anomaly, because that will reduce the contamination of the urinary tract, but also provide the right environment when it comes to reconstruction and provide adequate environment for healing. So after their colostomy, they are stabilized in terms of their feeding and renal function, and stoma is working well, and we have achieved reliable urinary tract drainage. They are put on prophylactic antibiotics and then discharged home. This usually takes about 2 weeks. Now, further workup needs to be planned. That can happen on an outpatient basis. The top left, basically the principle is trying to understand the anomaly, or the anatomy, sorry, of the anomaly, so that the appropriate intervention can be planned. So we need to know the differential function of the kidneys and drainage. We want to actually examine them under an anesthetic using a telescope to understand what is the length of the common channel, what is the length of the urethra from the confluence to the bladder neck, because these are important parameters to decide what form of intervention they will need, because there is a spectrum, or there's a variety of options available depending on the anatomy. Surgical repair is done as soon as we have a child who is clearly thriving and the anatomy is clear. And it can be purely a perineal approach or an abdominal perineal approach. They're usually discharged in 5 to 7 days because their feeding starts very early because they've got a colostomy. Now, there is a small proportion of children who do not void even after reconstruction. Therefore, counseling has to accommodate clean intermittent catheterization in some children that will be necessary. So if you don't manage expectations like this, parents find it very difficult to deal with this after surgery, and you've not discussed this before. In about 6 to 8 weeks' time, colostomy closure is planned, and we take the opportunity to check things have healed up well, and if they have, then colostomy is performed. They are then discharged over the next few days and reviewed in about 3 months with a bladder function, assessment of bowel function, and creatinine. And then a few follow-ups are every 6 months over the first 2 years, and then it's a yearly follow-up. Now, coming back to our story. So this is the abdominal X-ray of the child, which was a huge soft tissue mass lesion occupying the lower abdomen, including the pelvis. And you can see the intestines have been pushed more cranially. And clinical examination shows a very small orifice at the tip of this sclerophallus. There is also some DSD work happening on the side, some hormonal profile, but they all come back as normal. And it's interesting, up to 30% of very large series go down the DSD route also, to know if there is any hormonal imbalance. The ultrasound comes back. There's bilateral hydronephrosis with some distortion of or abnormalities of the parenchyma, and further down there is hemivagina, which is distended in the right picture, and a collapsed bladder. There is also some free fluid in the abdomen, which is not surprising. The shunt is removed and a catheter is placed into the common channel. It is advisable not to inflate the balloon because that can actually be counterproductive in drainage. So just a catheter is enough to drain the system. Now, in most, this drainage can be achieved by just this catheter alone, but in others, you may have to place a tube into the hydrocolpos or a suprapubic catheter into the bladder. And last but not the least, sometimes, very rarely, they end up having a vesicostomy, but preferably not. It should be avoided if possible. So the child is planned for a colostomy. We generally do a transverse colostomy so that the distal bowel is available for pull-through. So laparotomy is done on day 2. What we find is quite a harrowing experience. There is extensive matting of bowel because there has been fluid in the abdominal cavity. It is urinary ascites that has caused a lot of inflammation and matting, and it's very difficult to identify the loop of bowel to be exteriorized. There's widespread bloody ooze. There is platelet and RBC transfusion and cryoprecipitate. And during this time on the table, the child has a cardiac arrest. This is quite a difficult time, but fortunately successfully resuscitated. And the ileostomy is done because we just couldn't know which was the right bowel or which segment of large bowel was the right one. A vaginostomy tube is placed and a suprapubic catheter is also inserted at that time. It is quite obvious that this child has had some acute kidney injury. The creatinine goes up over the first few days and then sort of stabilizes in the hundreds. And then over the next few weeks, the creatinine comes down. The child is then discharged and brought back in about 3 months to assess the anatomy. What is found is that through the single opening, a cystoscopy or a cloacoscopy is done, which shows a common channel about 4.5 centimeters. From the confluence to the bladder neck, it's about 1.5 centimeters. There is a duplicated Müllerian structures in the form of hemivagina and 2 cervices, and a rectal fistula joining the vaginal septum. And at about 6 months of age, definitive reconstruction is done, which involves a pull-through of the rectum and the urogenital mobilization. Unfortunately, 2 weeks after when the catheter is removed and the suprapubic is clamped, the child doesn't void. CIC is attempted, or clean intermittent catheter is attempted, but that fails, and scopy is done that confirms the urethra has strictured. A suprapubic catheter is then placed. Child is sent home with suprapubic catheter for a few months, and then a Mitrofanov is done at 9 months of age. Child grows. At 8 years, the creatinine is sort of 50 is normal, 55, a GFR of 94. And then she's now currently 12. She's attained menarche. She's managing her catheters herself through the Mitrofanov. She's dry and clean, doing well at mainstream school. She's had a few urinary tract infections, but they were promptly treated. Storage urodynamics look quite encouraging with a stable and compliant bladder, no reflux, normal kidney function. Nuclear medicine does show some scarring, but creatinine is normal. The next stage is to plan for assessment of the vagina and introitus in anticipation for future sexual function. So that's in the future. Looking at the historical group from our center, it is quite clear that a lot of them have CKD. So much so that 50% have CKD by 5 years of age, and about up to 20% of them end up with end-stage renal failure requiring a transplant. And in that series, there were up to 5% mortality. What came from that paper is that reflux, dysplasia, and acquired scarring were independent risk factors for CKD. And if they had one kidney, almost all of them had CKD. Now, this is our current cohort of patients who started their life with us since the beginning of our MDT service. There are 25 of them who are almost 5, so a similar sort of cohort. And what you can see is CKD is only 16%. 84% of them have normal GFRs. And you can see the distribution of CKD, and 4 of them have got acquired scarring. So I would say significant difference with the start of the MDT. And I suppose the reasoning behind that is because there is a defined pathway of care, that infections have been promptly treated, the investigations have been appropriately timed, and close follow-up is maintained. And therefore, this has translated into better kidney function or preservation of kidney function in the majority of them. So management, just to summarize, can be quite challenging in these patients. The anatomy is vital to provide the best solution, because I've only discussed one surgical approach. There are other approaches described depending on the anatomy. Urological emergencies, which happen quite early, have to be promptly dealt with to have a good outcome. Associated anomalies also are there, and they are present and need appropriate management too. Now, it needs to be emphasized that this complex condition has to be managed in an MDT service, where there are people with different skills contributing to the holistic care of these patients. What I've not mentioned here is the psychology. Now, this is our MDT team, and what the person behind Divesh, the lady there, is our psychologist. And psychology is an integral part of our service, which is offered to all patients, not just patients who need psychology, but it's offered to all of them. Thank you.
Dr. Abraham, an outstanding talk, and this is a mixed audience. So I think what we need to emphasize, and what you have beautifully brought out, is how a multidisciplinary clinic of experts can actually produce outstanding results for a non-surgeon to understand that only 2 of your children in your group have a GFR of less than 60 is something that's, I mean, it's a dream outcome. I don't think any of us have results like that, but then we are all solitary people, and for you to come together as a group and fire is just fantastic. And a couple of things, you presented a beautiful case with all its complexities, and you didn't hide anything. And I think you brought it out very well. A few questions that people have asked is condition. Is there something that, something that people should know?
Yeah. Sorry, I missed part of the last bit of what you said.
The genetics of this condition, is there something that we should know? Are there any specific genetics in a cloacal anomaly?
Not
That's
yet.
what I think is the question.
Yeah, we're not aware of a defined genetic abnormality.
Yes. Okay. Another question is, why a lateral pelvic X-ray? What is
That is, yeah.
TWOC?
So a lateral pelvic X-ray was, so this is a pathway that we have done when we started the MDT service. And I have to say, we don't do lateral X-rays anymore. It doesn't help with prognosticating them or defining a management strategy. Sorry, you're breaking up.
Sorry. No. What is TWOC in your slide? You had TWOC.
Trial without catheter.
Trial without catheter. Okay, fair enough. And finally, there's a question from Argentina, whether you admit your children in the follow-up clinic for surveillance of their growth, neurodevelopment, and behavior. How exactly do you follow them up subsequently? Because that's a very important part of their follow-up.
Yeah.
Do you sort of periodically ask them, admit them?
No, we don't admit them unless there is a need to assess their urinary tract.
Okay.
The neurodevelopmental, so our team has outreach connections with the community pediatrician. And so it's not just us involved in their development and growth in the hospital. There is a defined community pediatrician that is also involved that looks after their growth and development. But in our clinic, the psychologist also plays a very important role in assessing their development, their interactions, and their behavior. All that is part of the assessment during the MDT clinic.
Okay, I think that's very valid, very valid. Finally, there are a couple of surgical questions from Dr. Balamurugan, which I think you should look in the chat box and answer. It may not be relevant to the majority of the audience here, and he's asked some pointed questions. And as I said earlier, perhaps in our surgical group, we need to discuss the management of cloacas some more, primarily because of your enormous experience and your wonderful result. Thank you very much.
Thank you.
If Dr. Divyesh is ready, can we go ahead with your talk, sir?
I will almost certainly try again. So I've had some communication with the IT support. The only thing I can think which may have prevented it is that the link has been sent to me through my work email. I'm working remotely, and I'm just wondering whether that is what is preventing me from accessing, because I'm struggling even now. My PowerPoint is open and I'm unable to visualize the share screen. So that's the only possibility that I can think of. Abraham, have you accessed it through work, or have you done it through the link through another route?
No, I
Divyesh,
forwarded.
is the option visible for you?
Sorry, which option?
While Divyesh is still trying, there's a question on in cloacal malformation, is it common to have lower spinal cord dysraphism? Abraham?
Yes. Yeah, as I said, it is very common to have a variety of malformation, but spinal dysraphism is a very common abnormality. And they all get an ultrasound of the spine along with an ultrasound of the urinary tract in the first few days, because we don't want to miss the opportunity while the window is still open to scan their spine. Because after three months, it becomes impossible to scan. And then you have to resort to an MRI.
That's an excellent point. Excellent point. The other question is, do you have any age or weight criteria when you decide on your various stages of surgery for the cloaca?
Yeah. So for the definitive reconstruction, there is no reason to delay the definitive reconstruction once you have confirmed clearly a child who is thriving, and number two, the anatomy is clear. These are the only two criteria. We don't generally look for weight, but just to give you a rough idea, that definitive reconstruction happens between 6 to 9 months.
Fair enough. Fair enough. Fair enough. Fair enough. So before they are discharged from the hospital, you would do a colostomy and you would subsequently call them back for all the other procedures.
Yes. So what happens is we want to one, establish safety.
Okay.
Secondly, we want to have a balance of how much time they spend in the hospital.
Okay.
Once we have established safety, once we have reliably established urinary tract drainage, a child who is feeding clearly, we have assessed the most emergent anomalies. They get discharged purely because all the other investigations can be done on an outpatient basis. There is no reason to keep them in hospital.
I think the point that you made about urinary tract drainage is very important. For the non-surgeons, getting adequate urinary tract drainage in cloaca can be particularly troublesome. Because
Yes.
a huge distension in the vagina with mucus, and that can cause a tremendous distortion in the anatomy. Getting drainage is not easy at all. Though, you know, Abraham made it look quite simple with the catheter down in that single orifice. Sometimes it can be nightmarish to get drainage of urine.
Yeah. So generally, there is an escalation or a cascade of options available depending on the success of the initial option that is chosen. The least or minimally invasive way of drainage is to put a catheter and assess the upper tracts, see how they look.
Okay.
Once the catheter has, proven to be ineffective, the next thing is to achieve drainage of the vagina alternatively, usually a percutaneous drain into the hydrocolpus. Now, interestingly, I don't know if we still have time, but if Divesh is ready, I'm happy for him to go ahead. Otherwise, I can continue the discussion.
Divesh,
I don't want to wait.
Anytime you're ready.
I think from my end, there's been an issue. I've emailed my presentation to Sukanya. I'm not sure if she's received it and can project it from there.
Yeah, I've received it, so I'll project it for you. Just give me a second.
Okay, great. Thank you. Thank you. Not sure, cannot understand why this has not worked.
So on behalf of everyone, Abraham, a brilliant presentation on a very difficult condition. Thank you very much for sharing your experience in this very interesting and difficult topic.
Thank you.
So while Sukanya is sharing, firstly, let me thank Sukanya and the organizers for asking me to be part of this meeting. And she has asked me to talk on low urinary tract needs. Posterior urethral valves, where we've already had quite a bit of discussion, continues to remain the most common cause of low urinary tract obstruction in male infants, with an estimated incidence of 1 in 5,000 live male births. As the next slide will show you, this is a postmortem specimen which documents that it is a pan-urinary tract disorder with a variable spectrum of severity, which affects both the upper as well as the lower urinary tract. Next, please. Next slide, please. So Hugh Hampton Young was the first person to describe the classification, and that was based on post-mortem dissection studies. Now, unfortunately, due to the technical problem, I cannot show this video. And 95% of the valves are type 1, and a small proportion of 5% is type 3. Now, this was revisited with an endoscopic appraisal in an uninstrumented urethra by Paddy Devan and Philip Ransley, and they described the congenital obstructing posterior urethral membrane, which is a transverse membrane in the posterior urethra that is proximally attached to the verumontanum. And within this membrane, there is a variable sized aperture that is located within it, and it is usually in an eccentric position. Next slide, please. Next slide, please. So as we've already discussed, certainly in the UK, more than 80% of cases are suspected on antenatal screening. And this is not across the UK, but the 12 and 20 week scans are pretty much routine. And more recently at University College, we've also added a third trimester scan at 32 weeks. And this tends to pick up the majority of cases that get referred to us at Greater Ormond Street. In those cases that are not presenting with an antenatal history, I'm sorry, I'm going to skip this slide because we've discussed the antenatal findings in the previous discussions. So as a neonate, they would present with listlessness, poor feeding, irritability, a failure to thrive, a poor urinary stream described by parents, and occasionally presence of abdominal masses. Next slide, please. So we start with our postnatal imaging, which is an ultrasound scan. And the features that you look for are a thick-walled trabeculated bladder, presence of hydroureteronephrosis, and incomplete bladder emptying if the child is spontaneously voided. Next slide, please. The micturating cystourethrogram remains the gold standard, and the features radiological on the MCUG include a trabeculated bladder, a dilated posterior urethra, an abrupt change in caliber between posterior and anterior urethra, bladder neck hypertrophy, and vesicoureteric reflux. If there are more than 3 features present on the MCUG, then that would warrant a cystoscopy to confirm the diagnosis. Next slide, please. Moving on to the management, and I'm going to go back to a earlier discussion in a minute, but antenatally, the options that are open to us are watchful waiting, termination of pregnancy, bladder aspiration, and vesicoamniotic shunting. Next slide, please. From a postnatal management perspective, there was some discussion about timing of postnatal intervention, ultrasound, etc. And we also touched upon the vesicoamniotic shunting and fetoscopy. Now in the UK, there was a trial called the Pluto trial, which was aimed to try and address the question of benefit in vesicoamniotic shunting in children with suspected posterior urethral valves. Unfortunately, so the trial was based on the uncertainty principle, i.e. The potential outcome would be an unknown. And the study had to close early because of poor recruitment, and therefore this question was not conclusively answered. Next slide, please. So coming to early postnatal urological management, the first thing that we would do in a case who we suspect has got bladder outflow obstruction is bladder drainage. And then you have time to try and attain homeostasis, get the fluid electrolyte and acid-base balance. And it is usually a good idea to get your nephrology colleagues involved at an early stage because the majority of these patients will require joint care going forward. And of course, prevent sepsis in this early period. Next slide, please. So bladder drainage can be achieved either with an infant feeding tube or a small Foley catheter, and where necessary or possible, a cystofix mini-ped inserted suprapubically, certainly in certain situations has an advantage. For example, feeding tubes falling out usually in the middle of the night, requiring a registrar or somebody to go in and try to reinsert it. And in these cases, for people who have catheterized, you'll be aware that the bladder neck can be a bit high, and it can therefore be a bit difficult to recatheterize. Next slide, please. Primary valve ablation is the preferred initial treatment. Diversions, either in the form of a vesicostomy or supravesical diversions, are indeed uncommon. Next slide, please. Now, unfortunately, there's another video which I'm unable to share with you, which would have demonstrated a cold knife technique of the valve ablation. So we can skip this slide and the next slide and move on to the one after that, please. Yeah, skip that as well, please. So the vesicostomy or urinary diversion is on occasion considered in situations where there is very severe renal function impairment and or deterioration in renal function on catheter drainage. Sometimes it is considered in situations with gross bilateral VOR, and equally uncommonly where you don't have a suitable endoscopic equipment in terms of miniature and size, and therefore you want to buy some time by creating a diversion. Next slide, please. Diversions are not without problems. So I think it is particularly important, and particularly when considering supravesical diversions. So the common problems associated with urinary diversion are prolapse, stenosis. It can create a difficult situation with pyocystis. And with the supravesical diversions, yes, in the short term, you have bought some time and things move along quite nicely. But when it comes to reversing that or repairing and reconstructing that, it can on occasion be extremely challenging. And of course, in an older child, in a child who's in the nappy age group, of course, a diversion is quite easy to manage. But in an older child, managing with a diversion is more difficult. Next slide, please. So is there any advantage or when you compare primary valve ablation versus urinary diversion? And several people have looked at this. And in terms of the outcome of renal function, yes, there is some advantage that the renal function can be improved in the short term, but in the long term, there is no benefit of urinary diversion. Similarly, there is no influence on renal failure or body growth in the long term. What about bladder function? Bladder function, Kenneth Glassberg, in his publication has suggested that the bladder function is not detrimentally affected, and in fact, paradoxically may improve it. And Origitha, and similarly, we've had a study from Great Ormond Street and Guy's Hospital, which shows that there's no significant difference in bladder function, whether they have urinary diversion first or primary valve ablation. Next slide, please. Adjunctive procedures. Now, this was alluded to earlier, and of course, you know, the situation in India is very difficult, different to what we have in the UK. We would routinely carry out a check cystoscopy, even if they've had a cold knife incision, but almost certainly if they've had a Bugbee electrode ablation of the valve primarily. We also would offer a circumcision, and particularly if they've got significantly abnormal upper urinary tract, then we would advise that a circumcision in the long term would be beneficial for the child. Just a mention at this point about the reflux, which is quite an elegant way in children with significant renal impairment, because we'll come to the outcome of bladder function in a minute. But in the early stages following valve ablation, these bladders have quite significant detrusor overactivity, have a reduced functional capacity, and high voiding detrusor pressures. And if you want to alleviate that in the short term, then a refluxing ureterostomy, obviously the child will need to have significant reflux for that to be successful, is a good option to protect the upper tracts in the short term. Next slide, please. So let's look at the outcome. First, we'll look at the outcome of renal function, and then we'll come to bladder function. Next slide, please. So long-term morbidity in boys with valves is well established. Helen Parkhouse looked at the outcome of 98 children who were initially treated at Great Ormond Street Hospital and subsequently at University College in adolescence and adulthood. And she showed that in that cohort of 98 children, a third of them had developed end-stage renal disease, a third of them had impaired but stable renal function, and a third of them had relatively normal renal function. Next slide, please. And at the moment, approximately 25% of pediatric renal transplantations have a primary underlying diagnosis of posterior urethral valves. Next slide, please. And she went on to prognosticate that poor prognosis was associated with early presentation, that is age of presentation being less than a year, The presence of bilateral VUR was associated with poor renal outcome. Urinary incontinence at age 5 years was associated with poor renal outcome, and a plasma urea on discharge of greater than 10 millimoles. With the advent of antenatal diagnosis and the low threshold for investigating children with male children with urinary tract infections early, I think we can revisit some of these prognostic criteria. I think rather than age at presentation, the early presentation during gestation with small echogenic kidneys almost certainly will be associated with poor renal outcome. We have done a study in a cohort of 50 patients followed prospectively, and we found that there was no correlation at age 5 years between ongoing some degree of urinary incontinence and long-term outcome of renal function. Rather than bilateral VUR, it is the presence of bilateral abnormal kidneys that would associate with poor renal outcome. And the renal status at the outset, a GFR at a year of age, would be a good prognosticator of what the long-term renal function outcome is likely to be. Next slide, please. There are certain pop-off mechanisms which have been described, which are suggested that are protective in terms of long-term renal outcome. The VURD syndrome, as described by Duckett, presence of bladder diverticuli, urinary extravasation. Paddy Divan suggested that the size of the aperture in the obstructing membrane correlated with changes in the bladder and upper urinary tract. And Kenneth Glassberg has postulated whether it is the timing of urachal closure that determines the long-term outcome of both bladder and kidney function. Next slide, please. There is, however, universal agreement that secondary renal damage would occur in the presence of obstruction and infection, reflux and infection, obstruction with vesico-ureteric reflux, and a non-compliant bladder. Next slide, please. So let's look at the long-term outcome of renal function. And here I've chosen 3 studies. The first is Helen Parkhouse's study, which I've already alluded to. The second, which I mentioned, is a long-term outcome study on 50 patients, our cohort at Great Ormond Street Hospital. And of these 50, 60%, that is 30 of them, had an antenatal diagnosis and 20 presented in the postnatal period. Helen Parkhouse's cohort, of course, were all postnatal diagnosis. And then the third cohort we have is from David Thomas, where 26 patients, all of whom had a prenatal diagnosis. And if we look at the proportion with normal renal function or renal impairment, which is stable, it is in the region of around 80%. And end-stage renal disease, depending at what point you look at it, is between 20 and 33%. Next slide, please. So now we are going to look at what is the outcome in series where they have shunted patients with suspected bladder outflow obstruction. And the reason I've put late shunting is the vast majority of these, the shunting would be around 28 weeks of gestation or later once oligohydramnios has developed. So the first series is from Friedman, who had a mixture of diagnosis. Postnatally, 4 were found to have valves, 7 had prune belly, 1 urethral atresia, 1 megacystis, and 1 reflux. In comparison, Umberto Nicolini's series of 10 patients, all postnatally had confirmed diagnosis of posterior urethral valves. And when we look at the outcome of renal function, it is interesting that you can see that there is no significant difference between these 2 studies and the 3 studies that I've alluded to earlier. So roughly a third of them have end-stage renal failure, and between 70 and 80% would have normal renal function or renal impairment, which is reasonably stable. Next slide, please. Moving on to bladder outcome, bladder dysfunction has been described in up to 70% of children treated for posterior urethral valves. And Gundela Homdahl and Marja Di Gennaro have done long-term serial investigation of bladder function in these children through childhood. Next slide, please. Initially, in the first year of life, following valve ablation, the bladder tends to have a reduced functional capacity with detrusor overactivity and tends to be hypercontractile or generates high voiding detrusor pressures. Next slide, please. Between the ages of 1 and 3 years, bladder capacity starts to increase, hypercontractility reduces, overactivity tends to persist, and bladder emptying is incomplete, not to completion, which is not unexpected because the children are usually not toilet trained and therefore the detrusor sphincter coordination is as yet immature. Between the ages of 4 and 12 years, overactivity reduces or completely disappears. Bladder capacity increases further. However, unfortunately, the detrusor's ability to contract reduces, and that results in increasing incomplete bladder emptying. Next slide, please. Homdahl also went on to compare 6 children in her cohort post-puberty and found that all 6 of them had evidence of bladder decompensation in late teenage and early adult life. A word on reconstruction. Previously, certainly when I was a trainee in the late 90s at Great Ormond Street Hospital, there were 3 main reasons why children came in to have augmentation cystoplasties. The first was children with bladder exstrophy. The second were children with myelomeningocele and neurogenic bladder. And the third were children with posterior urethral valves. Today, the frequency with which reconstruction is required or offered in children with posterior urethral valves is significantly reduced. And there is a place where most of these reconstructions are done, and that is in children generally below the age of 3 or 4 years who have end-stage renal disease and are awaiting renal transplantation. And as we looked at bladder function in this age group, the bladder function is as yet potentially hostile, particularly to a transplant kidney, and therefore reconstruction would be a consideration in selected patients. Next slide, please. And here is a recent presentation which looked at the allograft survival and biopsy outcomes in patients who had either a urological or a non-urological diagnosis. And it was reassuring for us to see that the outcomes were very similar, both in terms of sex, male and female, but more importantly in terms of underlying urological condition, whether it was posterior urethral valves, which tended to be the majority, or any other urological condition, which would suggest that over time, our management dysfunction has hopefully improved so as not to affect long-term renal allograft function. Next slide, please. So in conclusion, all boys with posterior urethral valves will need regular long-term follow-up throughout childhood. Bladder function is continuously evolving in this population of children. A significant proportion of boys with bladder dysfunction may develop bladder decompensation in later life, and that is something to be aware of. And it is very, very important that a safe lower urinary tract is achieved prior to renal transplantation. Moving on to some less common causes of lower urinary tract obstruction. Anterior urethral valves of the syringocele is similar in its presentation and upper tract changes like posterior urethral valves, and similarly needs to be treated endoscopically with further long-term follow-up depending on renal and bladder function. Next slide, please. We talked about urethroceles, and very, very occasionally you can have a prolapsing urethrocoele which can cause bladder outflow obstruction. I think the case that was alluded to, which had the antenatal punctures, there was a concern that that is what was happening because of the oligohydramnios, and very occasionally we do see that in a postnatal scenario as well. Next slide, please. Urethral polyps, again, extremely rare And if you focus on that posterior urethral region, you can see a faint negative shadow, and that is the polyp which was flopping and intermittently causing obstruction to the bladder neck, and was very successfully treated endoscopically. But again, these are very, very rare conditions. Next slide, please. Congenital urethral strictures are not a common thing we come across, but urethral atresia is certainly something, and it can be segmental, which can cause bladder outflow obstruction. And the next slide, this shows you a short segment narrowing in the membranous urethra, which can be successfully treated endoscopically with an incision similar to what you would do for posterior urethral valves. So I've tried to cover the common causes of lower urinary tract obstruction. The rhabdomyosarcoma I've not mentioned, to be honest, because I thought it was mainly about neonates, and that's not something that one would commonly see in that age group, but it would complete the differential diagnosis of causes of bladder outflow obstruction in children. I apologize once again for the technical issues, and thank you again once again for inviting me to be part of this program.
Dr. Divyesh, we're really sorry for all the technical problems that you had, but I think you sort of, you surmounted all that. Yours is a difficult topic. It's a scenario that needs to be covered. And there are lots of, because we are sort of running short of time, lots of questions on the question answer box and also in the chat box,
okay,
which if you can address, that will be great. But fundamentally, I would, if I
yep.
looked at your presentation and I were to summarize a couple of things that really stand out to me, is the importance of an MCU. Because in this country, we have a lot of people who do endoscopies and say they found valves, but really, I mean, unless you have an MCU confirmation, it's rather difficult to know it's a valve. And secondly, your one slide on the prognosis of PUB was, I think, was a gem, where you have shown all the various things that you have in your personal experience seen and which contributes to a good or to a bad prognosis. Thank you very much. I'm really sorry we didn't have time to discuss further, but I would request you to please answer all the
please
questions.
don't.
Yeah.
Yeah, please don't apologize, because the technical difficulty is probably at my end, not your end. The rest of the presentation seemed to be going smoothly.
Thank you very much. And thanks, Suganya, for giving us this opportunity.
Thank you. The next session will be on dialysis and nutrition, and this is being chaired by Dr. Sushmita Banerjee. She is a consultant, Department of Pediatrics at the Calcutta Medical Research Institute and Department of Pediatric Nephrology, ICH, Kolkata. She is a section editor, Pediatric Nephrology Journal, also the counselor for India to IPNA. She's a chairperson in IPNG and has published over 46 journals and is the author of more than 19 chapters. Over to you, ma'am.
Thank you very much, Pooja, and thank you, Shukarna, and your whole team for organizing this wonderful seminar and for inviting me to participate in it. Pooja, can we have the slide, the CV slide for Dr. Rukhsana?
Sure, ma'am.
It really gives me great pleasure to welcome Rukhsana to this program. You have heard a very thorough introduction with all her different thank you. With all that she has done listed in great detail yesterday, what I would like to say really is that you probably know that she did her initial training in India, and then she has really gone on to develop an international repute in the field of pediatric nephrology, particularly in setting standards for the treatment of CKD, particularly CKD and bone disease. And what is most impressive is, again, that she has tried to give back to the community by developing many educational models and training and teaching seminars and programs for all her colleagues and for the juniors in different parts of the globe. Rukshana, I welcome you and invite you to start uh, this session by talking about infant dialysis. Of course, infant CKD is a difficult issue in India, as we all know. The financial burden that it comes with is very difficult for many parents to bear. Um, but we do try to do the best we can for our children. And please start your talk on infantile dialysis.
Sushmita, thank you very much for your kind introduction. And thank you again to Sukanya and colleagues for an excellent symposium. Just to confirm, can you all see my slides and hear me?
Yes, we can.
Excellent. Thank you so much. So without further ado, I'm going to talk about infant dialysis and our experience, international and local experience. We'll go through the demographics of renal replacement therapy in neonates and infants, practical aspects of chronic dialysis, particularly focusing on PD, because we follow this talk with one from Professor David Ashkenazi, who is the international expert in extracorporeal dialysis in neonates. So I'm going to leave that tough section to him. I'll also briefly talk of complications and then outcomes. So demographics of RRT, as you see on this slide here from the ESPN ERADTA, looking at different age groups, the dark green color, the green colors here are PD and HD. And you see that in neonates, the commonest modality is peritoneal dialysis, which then reduces in its frequency, in its prevalence as age increases. An excellent international registry that comes from the ESPN, IPPN, the Australian and New Zealand registry and the Japanese registries all put together discusses the rare event of dialysis in neonates. Here, these 5 registries across 32 countries have gathered data in 264 patients, all of whom started RRT within the first month of life, with about half of them in the first week of life. And they follow these children through looking at outcomes. So just let me get my laser pointer. Yeah. So in this cohort, the main causes of renal failure were CACUT and cystic kidney disease and tubular necrosis. And the most common modality of RRT by far was peritoneal dialysis. Some of these children had a residual urine output, but there were many who were also anuric. So let's talk about PD in infants first. Infant PD catheters can, for the long-term use at least, should be flexible swan neck catheters where possible. These catheters are actually sort of miniaturized versions of adult catheters we use, but you will see that there are very distinct markings giving us the distance from the catheter tip to the first and the second cuff, so that the surgeon can carefully plan its placement, of course, aiming for the catheter tip deep in the pelvis. Catheters can be single or double cuffed, depending again on the size of the patient, where one may not even be able to fit in 2 cuffs in the tiniest abdomens of neonates. And the exit site of the catheters should ideally be downward pointing, as in older children and adults. There should be this permanent bend or the swan neck between the the catheter tip and the cuffs as well, and it can be either straight or coiled. As with all PD catheters, wherever possible, we should aim to embed the cuff, the superficial cuff in the subcutaneous tissue, and the deep cuff within the rectus muscle. Now, all this is clearly easily said and done when you have a tiny neonate with a very fragile abdomen, often with edema in it. It's like trying to put something in a sponge, in a very slender sponge, and this can be extremely challenging. A common complication seen is this complication. Here you see that the side holes of the PD catheter are engulfed by the peritoneum, and clearly this peritoneum is not going to, this catheter is not going to work, and any outflow from it in particular will be obstructed. This highlights the importance of the need for an omentectomy wherever possible, and particularly in the younger children who need PD. So some practical tips about access, PD access in these children. A partial omentectomy is recommended wherever possible. The exit site of the catheter should be away from the diaper or nappy line and away from any stomas where possible. The exit site should be downward or lateral pointing. This catheter should be immobilized by dressings and anchor tape immediately after insertion to try and get the best possible seal one can. And again, given the very friable abdominal wall of these babies, where possible, try and rest the catheter before starting PD. Now, of course, this concept of resting a catheter can be a bit of a luxury if you have a very sick child, but where possible, do try and rest it. So having said all this about what not to do for PD catheter placement, there are many exceptions. And sadly, we often have more exceptions than babies following the textbooks. So this is a little infant with a colostomy. And you see that the PD catheter has actually been tunneled onto the anterior chest wall. Here, this gives a sort of pictorial diagram of this and the catheter tunneling here. So this has very successfully achieved a long distance as best as possible between a dirty stoma and what should be a sterile exit site. However, the long length of tunnel can predispose to infections, but this is a life-saving measure and has been done in other babies with colostomies. Now, looking at the PD technique and program itself, PD in infants and neonates can be manual PD, which is required in infants under 2 kilos, and those who have a fill volume less than 60 mils. The other technique, of course, is automated PD. We do this on the home choice machine, or it can be done on the Fresenius Sleep Safe as well. So a manual PD set pretty much looks like this. It's simply the PD fluid in these dispensing bags. You see a double chamber bag here for physionyl fluid. You see the burette to very, very carefully measure out the volume of fluid that is being given to the child. And then you have this sort of Y piece for drainage of the dirty fluid. One also needs a heater system so that cold fluid is not poured into a baby's abdomen. And with this very simple device, which actually, although available as a set, can also be easily made manually, just like your IV sets would be. And this provides the technique for PD dialysis here. So individualizing this PD prescription, we start with a low fill volume, steadily building it up, and the optimum volume, of course, is required to enhance the clearance of small molecules such as urea. One aims for a fill volume of about 800 mils per meter squared, keeping in mind that too large a fill can lead to hernia, pain, gastrointestinal reflux, and a leakage from the exit side. The dwell time and number of cycles is adjusted based on the size of the child, whether or not they still have a urinary output, and keeping in mind that infants are usually invariably high transporters or fast transporters. That means they need frequent short cycles in order to achieve and maintain the osmotic gradient of the dialysate fluid. A manual PD prescription at the very start of dialysis would look something like this. One starts with extremely low fill volumes with the fill time of about 10 minutes, a dwell of 30 minutes, and a drain of about 20 minutes. So each cycle is about 1 hour. This can very easily be shortened down substantially, and we often do cycles of even just as short as 30 to 40 minutes. The manual PD program is slowly increased, again, depending on the urgency of the situation, the need of the baby, and also their tolerance and any leakage. But by increasing fills by 5 to 10 mils per kilo until the child reaches a fill of about 40 mils per kilo or 800 mils per meter squared. Now, moving on to a home choice or a machine is well and good. It takes away the intensity of performing the dialysis, but there are circumstances where manual PD is perfectly good and perfectly well managed in our own setting, in our cardiac intensive care. they prefer to do manual PD, and there's absolutely nothing wrong with continuing with manual PD other than that it is labor intensive. However, as one gets to a fill volume of more than 60 ml, 60 ml, you can move onto one of the machines to do automated PD. And this ideally should be set in a low fill mode, which allows much smaller manipulations of the fill volume. And again, building up the fill to 600 mils to 600 to 800 mils per meter squared, keeping in mind a recirculation volume of about 17 ml within the circuit. So this is sort of the dead space of the circuit where no effective dialysis is achieved. The program in minimum drain, in the drain times and volumes can be adjusted in small adjustments, and ultrafiltration alarms can be set. Now, some common problems in infants are mechanical problems with the PD catheter, such as the diagram I showed you. Infants can often have a low blood pressure, and this is because of inadequate autoregulation in the infant, but also very importantly because of a loss of sodium into the PD effluent. And this can be as high as 70 to 100 milliequivalents per liter, often necessitating sodium supplements in these children. Now, this sounds almost contradictory that you're giving a child on dialysis sodium, but this is extremely important, A, to maintain their blood pressure, and B, to allow growth. These children are also prone to hernia, poor growth, and hypocalcemia and renal bone disease. Now, the blood pressure control I told you about is seen in the large registry study I mentioned. Here in infants up to the age of 3 years, one sees that the youngest infants are most likely to in fact be hypotensive and or have a low normal blood pressure. Whereas whereas if you see this in older children and adults, usually they're above 2 standard deviations. So there is a real risk of this. And again, largely because of sodium losses on PD. As I said to you, infants are high transporters or fast transporters, and therefore their ultrafiltration related convective solute transport is high. They lose sodium through the small pores of the membrane, through convective clearance, and of course, a little bit also through the large pores. So PD-induced hypertension is a well-known entity. The sodium depletion will reduce extracellular osmolality, leading to hyponatremia and hypovolemia. And in addition to this, the infant may have a failure of autoregulatory mechanisms or certainly underdeveloped mechanisms. And over and above this, excessive UF, antihypertensive medications, or the common infections with fever, diarrhea, or vomiting in these children can all lead to instability. And one of the most severe acute complications here is our watershed infarcts, such as anterior ischemic optic neuropathy. Now, this is a well-known complication of dialysis, fortunately very rare, but in the watershed infarct in the eye, in the retina, and can also happen in the brain. Here, this small study has compared children or infants rather with anterior ischemic optic neuropathy versus age-matched controls. And they see that the most significant factor here is a lower systolic blood pressure in these infants. So do not be fooled by, do not be misled by thinking you have achieved very good blood pressure control. Do consider using sodium in these children and keep a very, very close eye on blood pressure regulation. Very briefly to talk about infant HD. The challenges of this are largely with vascular access and associated problems with blood flow and clotting of the circuit. Blood volume in a standard HD circuit is about 60 to 80 ml, which can be a substantial part of the child's total blood volume, meaning they're prone to hypertension and to an immediate dilution of the baby's blood, such that blood primes are required, and this is often needed until the child is about 6 kilos in size. And inaccurate fluid removal on our machines can lead to unstable babies on HD, and again complications from hypertension. You've all heard of Poisson's law, where the blood flow through a tube is proportionate to the fourth power of the radius, meaning that the smallest lines have the highest resistance. So single and double lumen lines of the same gauge will have higher blood flow in the single lumen line. And this is important to keep in mind, suggesting that you'd rather have the same tube with alternating inflow and outflow rather than having a double lumen line. The vascular access size is important, and the pediatric chronic renal replacement therapy registry has shown this excellent and very dramatic picture showing that the 5 French catheters have the worst outcomes in survival and blood flow and should not be used at all. Hence, the smallest catheter size we use now is the 6.5 French single lumen line. I've actually taken the slide from one of Dr. Ashkenazi's papers, and I'm not going to steal his thunder, but just to say young children are dialyzed differently with so many different factors to consider, and I'm sure he'll be telling us a great deal more about this. So just very simply, in our own center, the access we use in the youngest children is 6.5 French single lumen, and as they get bigger, 8.5 French double lumen lines. The dialyzers are the FX speed dialyzer with a surface area of simply 0.2 meters squared and a volume of 18 mils at the smallest. The mini neonatal lines are used where possible, but this already gives you a large extracorporeal circuit at the very minimum of 47 mils, meaning that blood priming is needed until an infant's weight of 6 kilos is reached. The outcomes on infant dialysis, as outlined in that registry study, are important to consider. Here, over the 5-year follow-up period, the probability of death was high at about 20% in all children, the highest mortality being in the first few months of life. Dialysis survival, however, was good, and a number of children were transplanted by the age of 5 years. Treatment modalities changed, moving from PD to HD in almost all children over time. And again, a very small number, less than 1%, making some sort of recovery to coming off chronic dialysis, usually only transiently. The causes of death are listed here, largely infection related. And importantly, there was no significant difference in the risk of death based on the timing of RRT initiation, the treatment modality, so HD or PD, the primary renal disease, or across birth weight or the countries and registries. Neurological complications were associated with a 5-fold higher risk of death. Here we look at outcomes from the Britics this time, look between HD and PD, and they are comparable across modalities, although with a higher mortality in HD patients in the first few months compared to PD. So finally, the ethics of infant dialysis. Now, this topic alone deserves a dedicated conference with many days of discussion, but very, very briefly, it's really a balance between science, technology, and ethics. We are not well supported by technology in terms of the machines for the smallest infants. But remember, just because you've never done it doesn't mean you can't do it. So don't say no because you've never done it before. These babies deserve a chance. And just because we can do it doesn't mean we should do it. So again, just because you might have the technology, please consider each child as an individual in their family circumstance and choose the most appropriate therapy for them. I'm going to talk a little bit further about this in the next talk, and also on the challenges of infant dialysis, which are not just about the dialysis machine itself or the dialysis therapy. And so to conclude, the provision of chronic dialysis to neonates and the achievement of targeted outcomes is one of the most significant challenges in pediatric dialysis care. A highly skilled pediatric multidisciplinary team and a dedicated family are essential to achieve the best possible outcomes. High complication rates are mainly related to access and infections, and mortality data have improved over time, but we need additional efforts to decrease the associated morbidity and improve patient outcomes. Thank you very much. This slide shows some of our youngest babies we dialyzed and how they've grown up into beautiful young children. Thank you.
Thank you. Thank you very much, Rakshana, for a very comprehensive yet practical talk. Thank you particularly for also mentioning the ethical issues. Could we have the CV of Vanessa's CV up, please, on the slide? Thank you. I welcome Vanessa Shaw to talk to us on nutrition in CKD in infants now. Vanessa, I have worked with her a very long time ago, I think more than 2 decades ago, and I was really amazed at her dynamism and her involvement with every single patient who was admitted in the unit at that time. She has been involved with the Great Ormond Street team for a very long time and was head of dietetics there till 2017. Congratulations, Vanessa, for this major award, the national honor of the MBA for your services for children's healthcare. Vanessa is a reviewer for several journals and the editor of the Clinical Pediatric Dietetics, a textbook for pediatric dietitians. And she has also established the MSc in Pediatric Dietetics in the UK. And a very experienced and very knowledgeable person who will show us the way we should treat patients with CKD, infants with CKD. I think this is the most important component of the care of these children. Thank you. Please, can we start sharing your slides, Vanessa?
Thank you very much for that introduction. Can everybody see and hear me?
Yes, but we can't see your slides yet.
Oh, they're on the screen? I'll just try again. One of the other participants is sharing, so I can't share mine. I'm getting a message say one of the other participants is sharing the screen, so I can't share
Pooja,
mine.
you stopped sharing, I think, didn't you? Pooja?
I've stopped sharing, ma'am.
Can you just check, is anybody else trying to share? Yes, it's just started to come up.
Can you see it now? Good.
We can, yes. Can you go to the full slide mode? Great.
Yes, it's on.
Yes. Thanks.
Well, thank you very much for inviting me to speak at this meeting, and also to highlight nutrition, which obviously is very close to my heart. And as you said, I've been practicing it with children with CKD for some 30 years or so. A lot of what I'm going to say today is detailed in clinical practice recommendations that the Pediatric Renal Nutrition Task Force has produced. So I just wanted to quickly introduce us. We're a group of 7 pediatric nephrologists and 7 pediatric renal dietitians from Europe and North America, and the group is co-chaired by Rakshana and myself. And our mission is to improve the nutritional management of children with renal diseases. And these are the clinical practice recommendations that we've had published in open access in pediatric nephrology, and you can also access them on the ESPN website, and I've just given the website there. So I would encourage you to read these papers if you haven't already. And alongside this, we've also developed practical guides for healthcare professionals. These, along with webinars discussing these aspects of care, can be found on this website I've given here, VitaFlow, which is one of the feed manufacturers in the UK. And they actually sponsor the work of the task force, but they have absolutely no input into our content. So we're safe from that point of view. We're not being influenced by a baby milk company. I just wanted to assure you of that. So providing adequate nutrition is essential in children with CKD, and it's particularly important in the infantile phase when growth is predominantly nutrition dependent. And nutrition obviously has an impact on linear growth. And when you consider that the maximal postnatal growth is in the first 12 weeks of life, and that 50% of adult height is normally achieved by 2 years of age, you can see that if there's any interruption to nutrition in the first year or two of life, it has serious consequences. Good nutrition also influences body composition, and we know that children with CKD have abnormal body components, high fat mass, low lean body mass, increased central adiposity, and they also have a low ratio of length of trunk to limb. Can good nutrition affect this? And also nutrition is going to have an impact on developmental delay. But is this more to do with the age of onset of CKD, the duration of CKD, or associated comorbidities? We don't know the answers to that yet. But this period of vulnerability of having nutrition-dependent growth is extended in CKD because that infantile growth phase may extend from 1 year of age to 2 to 3 years of age. And on top of that, these children are further advantaged in that many are born small already. And of a group of children that we looked at in Great Ormond Street, over half were either premature, small for gestational age, or both. So you can see these children are starting off with a disadvantaged growth. And so what are the consequences of static growth if we don't get the nutrition right? Well, in the first 12 weeks of age, if a baby's weight or length is static for just 2 weeks, they will lose 1 centile. And if their weight and length is static for 4 weeks, they've already lost 2 centiles. And to try and make those centiles up once they've been lost is really very hard. And this is illustrated very well on this growth chart I've shown you here of a boy with PUV and CKD who was born at 36 weeks gestation, so he was premature. And you can see, although he was a reasonable weight at birth, after birth, when his feeding was very poor, his growth was appalling. And you can see the growth chart here. The dots are his chronological age, and that's been corrected for his gestational age. And not only does it affect weight, but more importantly, length, and also has an impact on head circumference. So before we can start to feed these babies, we do need to do a nutritional assessment. And for infants, there are 2 essential elements. We need to do some accurate anthropometry. We need to get an accurate weight, a euvolemic weight, if they happen to be on PD or hemodialysis. We need to have a good length on them and their head circumference. And these must be plotted on a growth chart to make them meaningful, and we need serial measurements. And we recommend the WHO growth chart certainly up until 2 years of age. It's also important to know what the baby is actually having. And a dietary assessment is very easy to do in a baby because their intake of solids and milk, whether it's breast milk or formula, is pretty much the same from day to day. There are no biochemical markers of nutritional status in babies that we can call on. So once we can see where a child lies on the centile charts, we can get an idea of what their energy requirements may be. And the task force has a term that we have of suggested dietary intake, which I'll refer to as the SDI. And here you can see the SDI for both energy and protein from birth, that's for term babies, 37 weeks gestation, up to 12 months. And we derived these figures from looking at the published recommendations of a number of countries, the USA, the UK, the Nordic countries, German-speaking American countries, Holland, well, the Netherlands. And so we've averaged out those figures so that we have a range of energy and protein requirements. So to promote optimal growth, we suggest that the initial energy intake that you aim for is towards the higher end of the SDI. And same goes for protein. To promote optimal growth, we want the protein intake to be generous. So target protein at the upper end of the SDI. And just to say that this lowest level of our range is the WHO minimum safe amount. And we would absolutely recommend that protein intake doesn't fall below this, otherwise growth will be severely impaired. Just a few other notes about protein. Babies on dialysis will need to have a higher protein intake than the SDI that are quoted here. And having looked at the literature, we haven't had any reason to discount the recommendations of KDOKI, and these are the amounts of extra protein on top of the SDI that may be required for those on PD or hemodialysis. Now, if a baby has a persistently high urea level, and you've already discounted other levels of high blood urea levels, such as a catabolic state, or they're dehydrated or on steroid therapy, then we suggest adjusting the protein towards the lower end of the SDI to control high urea levels. But in children with CKD, we would not expect their urea levels to fall below the normal range. And if they do, then indeed that may be an indication that you're actually starving them of protein, you're not giving them enough protein, and you need to give a more generous intake so that you can optimize their growth. So what to feed these babies? Well, I think you'll all agree that we all follow the WHO recommendation of breastfeeding as being the preferred method for feeding any baby, and also those with CKD. And if mum's not able to breastfeed, then we encourage mum to express her milk so the baby can have the benefit of all of those bioactive factors that are found in breast milk. But if breast milk isn't available or there are inadequate amounts to provide full nutrition, then we recommend a weight-dominant infant formula, and these are sometimes called stage 1 infant milks, and I've listed here the ones which are certainly available in India. So, of course, breastfeeding and express breast milk can be given along with weight-dominant infant formulas. It doesn't have to be one or the other. So how do we optimize nutrition for those babies where they might have a fluid restriction or where they need a more energy or nutrient dense feed to meet their nutritional requirements? And I'm sure you've all experienced that these babies are very reluctant to feed. They vomit very easily. They will drink water by the litre almost. Many of them are polyuric and therefore polydipsic. So whilst they will happily take water, they are reluctant to feed. And so we do need to have a technique of fortifying either their breast milk or their formula when they're beginning to show a fall off in their growth centiles. And you can see the dramatic impact, not just on weight, but on length once you start to fortify feeds. But if you're concentrating feeds or adding any dietary supplements, it must be done in a gradual manner so that the baby will accept the taste, but also their gut will tolerate it. So first of all, if we have a look at fortifying express breast milk, we can add the weight-based infant formula to the mature breast milk, and these are the figures that I've given here. And you can see it's important to add the infant formula in increments of probably 1 gram per 100 mils of EBM daily, so that you can see that the baby does tolerate it. And if we're adding gradually up to 6 grams of infant formula powder added to 100 mils of EBM, express breast milk, then we're getting 1 calorie per mil, which is a concentrated feed and will certainly have an impact on the baby's growth. Preterm infants, then breast milk fortifier may be added according to the manufacturer's instructions. And again, I've given here the breast milk formulas that may be available in India. A similar idea if we're concentrating infant formulas. The normal concentration of most infant formulas is around 13%. That's 13 grams of powder to 100 mils of water. And again, we can gradually increase the concentration of the amount of powder added to 100 mils of infant formula to again achieve a feed that's about 1 calorie per mil, which will improve growth very dramatically. And this is the amount of calories that, calorie density that you'll find in commercial nutrient dense feeds such as Similac High Energy if you have that available in your countries. It is important to recognize though that as you increase the concentration of a feed, you're also increasing the osmolality, and this occurs in a linear fashion. So by the time you get up to your 20% concentration or 1 calorie per mil, you see the osmolality of the feed has increased up to 451. Now, we don't know what the upper limit of acceptability is for that infant gut, but it's probably about 500. So as you're getting up to a calorie per mil, you may find that the baby starts to get diarrhea. You may exacerbate any pre-existing vomiting or gastroesophageal reflux that they may have. And also, so concentrating feeds will also be giving larger amounts of phosphate, potassium, and particularly vitamin A, which can be toxic. And so we do just need to be careful when we're making these modifications. And just out of interest, a paper was published by Agarwal and co-workers looked at adding a breast milk fortifier to a preterm EBM, and they used Lactodex at a concentration of 4 grams per 100 mils. And the osmolality of that feed then increased from 300 milliosmoles per kilo to 392. So you can see that you do need to be careful when you're adding anything to infant formula or breast milk. Do it slowly so that you don't create GI problems. Now, there may be occasions when you wish to add just some extra energy to a feed because a baby is running high urea levels and you've already started to reduce the protein, but you're still faced with high urea levels and they may be catabolic. And adding just energy without the extra protein is one solution to try and get that urea level down. Now, if you have glucose polymers available, these have a relatively benign effect on the gut as far as osmotic diarrhea is concerned. And again, published work shows that if you add 2 grams of glucose polymer to 100 mils of feed, you increase the osmolality by about 30 milliosmoles per kilo. And how much a baby's gut will tolerate obviously depends on the maturity and the absorptive capacity of the gut. And if their gut's working relatively normally, these are the amounts of glucose polymer that you'll probably get away with. In the young infant, you can probably add between 3 to 5 grams of glucose polymer per 100 mils of feed. And in the older infant, you could probably get away with 5 to 8 grams. But if you don't have glucose polymers available, then of course you can add monosaccharides and disaccharides, but you will be able to add much less because of the osmotic effect. And obviously glucose has a greater osmotic effect on the gut than sucrose. And you may only be able to add 1 or 2 grams of glucose per 100 mils of feed before you start to get an osmotic diarrhea. For sucrose, it may be 2 to 3 grams. Now, if you're in the situation where you have fat emulsions available, these can also be added. And again, this needs to be done in a gradual manner. For example, 1 ml added to 100 mils of formula per day. And I've shown here the amount you can probably add without actually causing delayed gastric emptying and again, exacerbating any nausea or vomiting. Now, if you don't have fat emulsions available, then of course you can add oil. But of course, it will settle out. It has little effect on the osmolality, but if you are adding oils to breast milk or infant formula, you really do need to shake the feed very frequently whilst you're giving it to the baby, otherwise that oil will just settle up and stick to the side of the bottles. Again, how much is tolerated? Well, again, this work from Agarwal and co-workers, they added coconut oil at a concentration of 2 mils per 100 mils of breast milk and saw that there was no change in the osmolality. So these are options of when you might need to add just extra calories rather than making a more nutrient-dense feed. But of course, the challenge is that if you are adding non-protein energy to a feed to control abnormal biochemistry, then you do distort the protein energy ratio. And the ideal ratio for normal growth is about 7 to 12%. So that's, and you can see from this table that I've taken from WHO, that if you want more accelerated weight gain or catch-up growth, then the protein energy ratio does need to be higher, because if you're just adding calories, you're laying down fat. We want lean tissue to grow, so we need to be adding protein as well. So obviously, if you're just adding carbohydrate or fat to a baby's feed, then you're lowering that protein energy ratio. So the ideal scenario is to concentrate formulas. And actually, we don't advise to add energy alone to express breast milk, because you will so distort the protein energy ratio that growth can actually be inhibited and is detrimental to do so. If you are in a situation where you do need to add just energy to a feed, do make sure that you're giving at least the SDI for protein, so that you can support weight gain and linear growth as best as possible. So when it comes to complementary feeding, introducing solids, again, the Nutrition Task Force absolutely concurs with WHO recommendations that infants shouldn't really have solids before 6 months of age, but obviously that depends on the individual baby and needs individual assessment. But it is important to progress to varied textures and varied flavours according to the baby's cues and oral motor skills. And we know that if there's delayed exposure to pureed and textured foods in babies with CKD, this can cause feeding problems. And what we want to do with these babies is to give them as wide a variety of foods as possible, so that they can get used to having a healthy, balanced diet from a very early age. And data from the CKID study showed that children with CKD, and this is looking at children from 1 up to 20 years of age, had very undesirable eating habits. And fast foods was a large component of their diets, and was a major contributor of sodium, phosphate, energy and fat intakes, and those were undesirable fats as well. So we do want to try and not restrict diet, but occasionally we will need to have some dietary limitations, which I'll talk about a little bit later. Oral feeding is the preferred route whenever possible, because we know that tube feeding is associated with chewing and swallowing problems, food refusal, panic attacks, and poor development of oral motor skills. But even if a baby doesn't eat very much, then it is important that they have oral stimulation to prevent the development of food aversion. And as I said earlier, we try to make the diet as liberal as possible, because this will encourage more normal development and behaviours around food. We don't want a restrictive diet unless we have to do that because of blood biochemistry. So once we do see deterioration in weight centile, then we do need to intervene promptly. And as I said before, these babies are reluctant to feed, whether it's their milk feeds or with solids. And so if they have an inadequate dietary intake, then there are obviously some medical things that can be addressed. Doing what you can to help their gastroesophageal reflux, correct acidosis, make sure that they're not volume overloaded and their dialysis is adequate. So oral supplementation can be done, as I've suggested earlier, by concentrating feeds or by adding infant formula powder to express breast milk. We encourage high energy foods, and we would like them to have foods with a high nutritional value so that they're getting a good range of protein, vitamins and minerals. And again, foods can be fortified by the addition of adding vegetable margarines or oils to savoury foods. And we would recommend oils which are high in omega-3 fats like soya, walnut and linseed, or those that are high in monounsaturated fats such as olive oil. But if these aren't readily available, then other oils that might be more available locally are corn seed, rapeseed oil, safflower and sunflower oil. And again, by adding sugar, jam, syrup, glucose to sweet foods. And again, this obviously goes against all recommendations for healthy eating for healthy babies. But in the baby with CKD, we're not frightened to add fat and sugar to their foods, because they do need to have the energy wherever we can, because their appetites are so poor. If you do have the energy modules like glucose polymers and fat emulsions, they can also be added to foods and drinks. If babies can't meet their nutritional requirements orally, then it's recommended that enteral tube feeding is started without delay. And indeed, there are a number of studies which have shown an improvement in both weight and BMI standard deviations for tube feeding in children less than 2 years of age. And 6 of the studies that I've shown here also showed an improvement in their height standard deviation. So for short-term feeding, a nasogastric tube is preferred because it's easy to pass, non-invasive, though it may not be very pleasant for the baby or for the parent who's passing it. But for long-term feeding, and what is the definition of long-term feeding, it's debatable, then a gastrostomy device is advisable through whatever method you have, whether you're gastroenterologists, interventional radiologists, or surgeons do your gastrostomies for you. Now, I know parents may be reluctant to have a gastrostomy because they feel it's just another operation, but if it could be done percutaneously, it's a quick method of getting a feeding tube in, and actually it takes a lot of pressure off the family if they can put some feed down the tube rather than struggling endlessly to get their baby to feed orally. And there are obviously investigations that may need to be done before a gastrostomy is placed, and there are obviously precautions about babies already on PD, but I'd refer you to our clinical practice recommendation on enteral tube feeding to elaborate on that, and indeed Rakshana may cover that in her talk a bit later. So how can the formula or EBM be delivered? Well, tube feeding can be exclusive to provide all of the nutrition, or it may be supplementary to oral feeding. But it is very important to discuss the method of feeding with the family so that they're in absolute agreement about the route, the device, and that they're part of the team about how they're going to feed their baby, because they can feel rather out of control if feeding their baby is taken away from them and replaced by a tube. But my experience over many years is that the families begin to look on the feeding tube as a friend, and because they know that they can get good nutrition into their baby by tube feeding them, they weren't able to do by trying to feed their baby orally. So gravity bolus feeds can be given, and these can either be given as supplementary feeds after meals or to top up any unfinished oral feeds during the day. All nutrition can be given through the tube if necessary. If the child really won't take solids, then all of their nutrition can be given via the tube. But of course, they can be drinking water, which they like to do, so that they are still taking something through the oral route. And it's a good idea to offer drinks from a bottle or a cup, so that they do still have oral stimulation, and to still offer pureed or more textured foods when they're developmentally ready. Get the baby as they get older to be involved with messy play and to sit up at family meal times even if they're not eating anything, and to make sure they have some positive oral experiences like touching them gently on their cheeks, kissing them, being able to suck on a pacifier or dummy, letting them lick or taste foods, mouthing toys with absolutely no pressure to swallow. And again, allow the baby to self-feed, let them pick up a spoon, let them play with the food. They might take the spoon to their mouth. If you're lucky, it's more likely to go in their ear or in their hair, but absolutely no force feeding. And you may have support from various other healthcare professionals who will give the families ideas about how to desensitize the baby around their worries about oral feeding. If you do have a gastrostomy device and you have enteral feeding pumps available, then giving continuous feeds overnight again is a way of taking the pressure off the family. And again, I won't go into this in detail because it is more medical management, but slow delivery of a formula by continuous infusion from an enteral feeding pump can be beneficial with those that have more severe reflux. But again, just to be aware that if you're using a nasogastric tube for overnight feeding, it must be supervised because obviously there's a significant risk of aspiration, which can be fatal. The delivery, if a child has a lot of problems with keeping the food and the feed in the stomach, then jejunal feeding may be an option. Nasojejunal feeds tubes are very easily displaced and problematical. But if they have a gastrostomy, then a GJ tube would be useful. But if feeds are given straight into the jejunum, they must be given continuously because the jejunum just won't tolerate bolus feeds. And you can see from the example of this little boy I showed you earlier, it was only when he had Nissen fundoplication that his weight gain started to take off and his length also improved. So that probably is the last resort. So in the last few minutes, I'm just going to talk about some changes that we might need to take to a baby's diet. Having said we don't want to be restrictive, if the baby is hypophosphatemic or is hypokalemic, then we do need to address their nutrition. Serum phosphate and potassium are likely to be within normal ranges if a baby's breastfed or they're on a weight-dominant infant formula. But of course, serum levels will rise as their renal function deteriorates and is also exacerbated by the introduction of solid food. So as I mentioned, a suggested dietary intake for energy and protein. The task force have also set SDIs for phosphate and calcium. I'm not going to go into calcium in this talk, but just keep these in mind. When it comes to serum potassium, these are the levels that, again, we recommend is the normal range, but again, that will vary according to your own labs and your own practice, but that's just a starting point. But just to say that we're not interested in changing the potassium content of a diet unless a child is hyperkalemic. A high potassium intake per se isn't a problem unless it causes serum potassium to rise to unacceptable levels. But with phosphate, we do need to start limiting phosphate intake right from the beginning.
Vanessa, Vanessa, sorry to interrupt, but we're running a little short of time.
Sorry, I've just got one more slide to show.
Sure. Okay.
What I just wanted to show you was that there are some low potassium, low phosphate formulas available, and these have considerably lower potassium and phosphate intake than normal infant formula. And I know in India you have Similac PM 6040 available, which is a low phosphate feed, but isn't really appreciably lower than in its potassium content. And this is what I just wanted to show you, that when we're trying to control potassium and phosphate in a baby's intake, I've listed the major food groups here, which we're trying to promote to give high nutritional value foods. And the foods on the left-hand side are lower phosphate options, and some of those foods absolutely coincide with lower potassium foods as well. But there are some exceptions in fruits and vegetables and potatoes where you will need to start thinking about portion sizes, because unlimited intake of these high potassium fruits and vegetables will exacerbate the hyperkalemia. But we do recommend not to routinely omit vegetables, legumes, and fruit from the diet just simply based on their potassium intake, because their bioavailability is only 60%. And so you need to balance that against keeping the diet as varied as possible. We do recommend to continue breast milk or infant formula beyond 1 year because these are naturally low in phosphate and potassium. And as the baby gets older and they may start to take commercial foods, then do avoid any foods that contain food additives, because these can appreciably increase both the potassium and the phosphate content of foods that babies have. And just finally to show you that our practical guidelines for healthcare professionals have all sorts of useful information about the content of foods regarding their potassium and phosphate that can help you incorporate this into your dietary management and the advice that you give to these families. Thank you, and apologies for overrunning.
Many thanks, Vanessa, for very clear, very great presentation. I'm sure there will be lots of points to discuss. I can certainly think of a few questions, but since these are related topics, we are going to take all questions at the end of the 4 talks. So I hand back to organizers, Pooja. Vanessa, I hope you'll be able to stay around to take questions at the end.
I can stay.
Thanks. Thank you.
Thank you, ma'am. Next session is being chaired by Dr. Rajiv Sinha. He is the professor, head of the Department of Nephrology, Institute of Child Health, and also the consultant pediatric nephrologist at Apollo Hospital, Kolkata. I'd like to hand over to Rajiv, sir.
Thank you very much. And first of all, I would like to thank Sukanya and the entire team for giving me this opportunity. And for the last couple of days, it has been really nice. Without wasting much time, I would like to welcome Professor David Ashkenazi. He is the director of Pediatric and Infant Center for Acute Nephrology in University of Alabama at Birmingham. Professor Ashkenazi needs no introduction for academicians, particularly pediatric academicians and pediatric nephrologists, because he has generated number of papers on acute kidney injury, both in pediatric and neonatal, and he's currently the board chair of the Neonatal Kidney Collaborative, which most of us know is generating a lot of evidence in a field where there is really lack of evidence, the neonatal kidney. He will be speaking on something which we in India are really not at the moment doing much of it, that is the extracorporeal blood purification in neonatal AKI. And lastly, I'd like to conclude with a personal statement, which I'm sure Professor Ashkenazi does not know, that he inspired us. Like when I started my pediatric nephrology training in 2006, we did come across his paper in Kidney International on 5-year follow-up, which at that time was, I believe, the only paper which was trying to find out that no, AKI is not a one-off thing and you need to follow them up. That inspired us to have another paper on a 10-year follow-up on a smaller cohort, and which got published in NDT. So thank you, David, and it's all yours now.
Well, thank you very much for the very kind introduction, and I'm glad that I was able to kind of help you guys through that. I'm going to share my screen here, and so just let me know that you could see the slides.
Yes, quite.
Okay, great. Great. Well, thank you all for inviting me to do this talk. It's on extracorporeal blood purification neonates. And here's my potential conflict of interest. It's important that I tell you that I do consult for multiple companies that are working on devices for neonates as it relates to blood purification. And it's also important that I tell you that I'm going to be showing you pictures of babies that we've taken care of, whose families provide us and encourage us to tell their stories across the country and across the world. So what I hope to do in the next 20 minutes or so is to, convince you of two things. One is to try to get you to understand why it may be important in your neonatology ICUs to have an extracorporeal therapy to take care of these babies. These are dialysis devices are used across other ICUs, and I'll try to explain to you why I think they also need to be part of the neonatal therapies that we provide. And then go into detail about who, how, and when to perform kidney support therapy in neonates as it relates to blood purification and some of the details that you may need to think about. So AWAKEN is the Assessment Worldwide Acute Kidney Epidemiology in Neonates study. We published 15 papers from it. This was the first paper that came out. And without going into much detail, I will just tell you that as it relates to this topic, AKI was very common, about 30% of those that were enrolled, which was about half of the patients that were admitted to the NICU. And of those patients, the rates of AKI was about 30%, 10% mortality in those with AKI, only about 1.5% mortality in those that did not have AKI. And as it relates to this topic, it's important to note that of those patients that had acute kidney injury, which was 650, only 25 of them received kidney support therapy. And so if you look at kind of the entire cohort and how we think about it, is less than 0.5% of the patients in the NICUs that were enrolled in the study received renal replacement therapy, and only 4% of those with AKI. And those rates are much, much lower than pediatric and adult ICUs. And so I think for me, it begs the question, is it time to change our mindset of which babies can potentially benefit from renal replacement therapy, whether it's peritoneal dialysis or blood purification therapies? This is a review of some epidemiology studies on the use of renal replacement therapy, blood purification in children. And you can see different weight ranges, but these are kind of neonatal populations. And you see outcomes anywhere between 15% and 67%, but about 50% of babies who go on dialysis end up surviving if you pull all these together. And then here's some similar subjects here. Again, I don't have time to go into them in great detail, but just to say they're about 40 to 60% from one study to the other. In the PPCRT registry, which we published here, the second one, I wanted to show you the mortality differences between those who were greater than 10 kilos and those with less than 10 kilos. And you could see a very big difference, 40% to 67%. So almost a 25% lower survival rate in children who received CRT in those that were greater than 10 kilos versus those who were less than 10 kilos. And so it begs the question, was it because we're starting later? Is it because it's more difficult in babies? Is it there's more risk factors to the therapies? Or what is it that's happening? And I would argue that we need to bring this number up to at least the same level as in the pediatric ICUs. Besides acute kidney injury, we have started to use blood purification methods for patients with congenital kidney anomalies. And we've talked a lot about that here in this meeting today. I will tell you that as things get better in the fetal world, as we start to identify who can be shunted and who can have valve ablation, I think that the number of patients that we're going to need kidney support is going to increase significantly as these babies are able to live past the first couple of days of life. But if you look at some of these studies, and Rakshana talked about the von Straten article in great detail, the survival rate is not zero. It's pretty good. It's 75 to 85% survival to 5 years. So these patients can live, and I think that it's challenging to think about it because those registries were done 15 years ago, some of them, and I think it's not the full story about how many patients we could help with renal support therapy, and here's why. So many expected patients all over the world, when their babies, when they have an ultrasound and it shows that the baby has a kidney anomaly, they terminate the pregnancy. They said, there's no chance, there's no success here, it's time to stop. And sometimes when babies are born with kidney anomalies, they're born in places where they're not really have the opportunity to provide them the proper care. And I would argue that the care of how we've been taking care of these babies has changed over the last 5 years. And I'm going to show you a couple of examples of what we're doing in our hospital. But as we get better at providing kidney support therapy, we're able to support smaller and smaller babies and sicker babies. And I'll show you a little bit about what I mean in just a moment. And then the last thing that I'll mention is that those registries, like the one that Rakshana showed, really capture babies who survive the NICU hospitalization. And so to get into the registry, you have to be an end-stage kidney failure patient, which requires you to be 2, 3, 4 months of age. And so the survival rate of the patients who are born with kidney disease is lower than 75% if you captured those that never even made it to those registries. So why should you have an extracorporeal kidney support therapy in your hospital? I think that in the past, it was very, very difficult. And that's why the main reason why the rates of use has been so low, because even with the best practices, we know that CRT used to expose neonates to significant added risk. I could tell you that my neonatologists used to hate CRT. They called me very late in the process when the BUN was 150 or 200, when the patient was 50 or 100% fluid overload. And when we had conversations about it, about why is it that it's taking so long to call, essentially what they told me was, we hate this therapy. It doesn't work. It causes a lot of problems. Everybody's super anxious about it. It causes complications. The babies get hypotensive when you start. And essentially, the benefits and the risks aren't really in the favor. And we don't like to call you because it's just not fun. And so the risks and benefit ratio dictated to them that it's probably not a good idea to start. Well, I think that we need to change that balance, and we have. And the ways that we have are multiple ways. One is by education. Two is assuring that your policies and procedures and standardization of care is optimal, so that every baby gets the best care, whether it's that I'm on service or there's a new attending on service, whether there's a certain nurse or neonatologist on service. The standardization of care is very important. We have integrated quality improvement processes. We've developed safety nets and I'll talk about those in just a minute, to assure that these babies have a safety net for when they get hypotensive, for example. But really what's changed things more than anything else is having these smaller circuits available for these smaller patients. So talking a little bit about a smaller circuit, if the problem that we face is all these risks and challenges because the circuit's too big, which makes the extracorporeal volume too wide, which makes them have hypotensive events during initiation. Well, what happens if you just kind of avoid those problems by really avoiding that problem, by bringing in a smaller circuit? Same with access. If we're having such horrible time with access and we need a giant vascular access to provide renal support therapy, well, maybe a smaller circuit will allow us to use a smaller access. And so these, I will tell you, are a game changer in our institution, and it's completely changed how we think about kidney support therapy after we've been using it for now 6 years, because now the benefit risk ratio has significantly changed because there is such less risk and such little complications in our patients. The benefit risk ratio is now in our favor, so we can do things that we in the past wouldn't be able to do because of that equilibrium ratio was not in our favor. And so the advantages of these neonatal specific devices are that they have lower blood volumes, lower extracorporeal volumes, lower need for blood primes, smoother initiation, and smaller catheters. So here's what we did. We took this machine that was available in the United States and in other countries called the Aquadex machine, and it's designed to simply ultrafiltrate patients who have heart failure. So you put a patient on the circuit, the blood goes round and round, and then there's a little negative pressure pump here that just pulls off plasma water. It's a very simple, very to use device. What we did is we basically said, well, let's use convective clearance by giving 100 mils an hour of replacement fluid to the patient, taking that 100 mils an hour off, and essentially doing CVVH like we had been doing with ECMO, for example, with using kind of just separate replacement pumps. We hook in some heparin. We have a port for labs. We have a place to give blood products and to monitor anticoagulation within the circuit. And it's really a very simple circuit to connect and hook up. The challenge to this is the biggest challenge is that the pump that regulates the fluid and the pump that regulates the ultrafiltration doesn't communicate with one another. So you just have to make sure that you understand this and that everybody in your unit understands this so that you can address any potential problems. And we have created important safety nets that really should be in place for all babies, whether they're on peritoneal dialysis, especially if they're on Aquadex modified CVH, but whether they're on any type of fluid removal system. We educate everybody who's around about things to call. We have very specific metrics where they need to call the nephrologist for hypotension and tachycardia, differences between treatment and delivery rates. We measure the weights in these babies twice a day. And we have these thresholds on the hematocrit line that are in the Aquadex machine that will automatically stop the ultrafiltration removal rate if the hematocrit is rising too quickly. So here's our data from the last 7 years or so, up until 2020. This is the number of patient days we have done in the neonatal ICU. I could tell you that in our hospital, we do more patient days in the NICU now than we do in the PICU and the cardiac ICU together. And you could see that back in 2013 and 2014, we very rarely did CRT with kind of our traditional machine. And then once the Aquadex was really adapted, you could see the numbers of patient days have climbed exponentially for us. Here's our survival rates of all patients who receive any form of Aquadex CVVH. If anything, our trends are kind of going upwards. Again, hard to really make a lot out of this because the types of patients that we're taking care of are actually a lot sicker in the last 3-4 years than they were back in 2013. And here's probably the biggest quality improvement data that we show that really has changed everything. 98% of patients who go on therapy don't need anything to support their hemodynamic state. We don't give them extra doses of saline or pressors or anything like that. The 2% have been very mild occurrences where you have to titrate their pressors perhaps, or giving them a normal saline bolus or a dose of calcium. So it's very, very rare that we have any significant cardiovascular problems at initiation. And you can see here that our circuits last as long as other units, where more than 60% of our circuits are lasting up to 2.5 days on this therapy. So we no longer have this problem where 2 hours after we put them on circuit, we got to go back and start all over. We've published our data together with our friends at Cincinnati Children's Hospital and Seattle Children's Hospital, where we described about 100 patients that had these therapies in these hospitals. And I'll refer you to that for additional information. But what the messages that we say from there is you could put these kids on circuit without any problems. Generally speaking, not everybody survives, partly because these are really, really sick kids that we're taking care of, with a survival rate of about 50%. So to give you an idea of how we've changed in our hospital, I want to bring up a couple of cases. The first case is a baby who was about 3 kilos. He had a prenatal diagnosis of posterior urethral valves. And he came out very, very sick, very little lungs, intubated, placed on high frequency oscillator, and was placed on veno-arterial ECMO before nephrology was called. Okay, so they called nephrologist, and our young attending got this call and basically said, well, what are you guys talking about? We are not going to be taking care of this baby who's on ECMO, who's got such little lung function that, no one's ever done this before. We can't take care of a baby like this. The neonatologist, who had now had several years of experience with us, really was adamant that this baby deserved a chance, and the family really wanted to try. And so people said, sure, all right, let's try it. So to give you kind of a big picture view of what happened with this baby, we started dialysis via the ECMO circuit. The baby came off of ECMO at about a week. At that point, we transitioned to our Aquadex CVVH, came off dopamine at day 10, off ventilator at day 14, still had severe pulmonary hypertension, so required nitric oxide and sildenafil for up to 4.5 months, came off oxygen, came off CPAP, transitioned to peritoneal dialysis, and went home. He's now, this is a picture of him when he was 10 months. He somehow came off dialysis. He's living with a GFR of about 15 to 20 mLs per minute per 1.73 meters squared now. He's feeding well. He's on the kidney transplant list, waiting off any form of dialysis. And we're super excited for this baby to get a kidney transplant hopefully soon. Again, the message here is that this is a baby that in our institution, we were very hesitant to give him a chance. And he's this beautiful little baby now who is ready for a kidney transplant with really no other comorbid conditions. Patient number 2, I'm going to go in quickly, but similar story, 2,700 gram baby, maternal history of 7 miscarriages, had significant prenatal diagnosis of kidney dysplasia, was intubated, transferred to our hospital, placed on ECMO. They called us. I was on service. My response was, is everybody sure that this is what they want to do? And the neonatologist and the family said, yes, we really want to try, so let's try it. This baby was on ECMO for about a week. She had a gastric perforation shortly after coming off ECMO, so we weren't able to do peritoneal dialysis for her. She was extubated at 4 months of age. We stopped CPAP. We stopped Aquadex and transitioned to intermittent hemodialysis around 6 months of age. And if you fast forward to when she was 2 years of age, she got her first kidney transplant and was doing very, very well. Now with a kidney transplant. We have a third case. I'm not going to go into details, but I'll tell you that it's another case that started with life on ECMO, severe pulmonary hypotension, hypoplasia, and hypertension, is at home waiting for a kidney transplant on peritoneal dialysis. And so we've surprised ourselves with what we could do. And I think the reason we could do it is because, again, we've been able to avoid those complications, that very difficult process of taking care of these babies. If you look at our hospital's numbers over the last 7 years, these are patients who had severe congenital kidney disease, not the ones that were on PD. Many of our patients go straight to PD and they do fine. Their rates are better. These are ones that required us to start CRT for one reason or another. Our mortality rate is about and our survival rate's about 50%. Great, so shifting to kind of the second part is, well, if you're gonna do it, who, how, and when are you gonna be doing this? I'm not gonna make the case that PD is better than extracorporeal therapy, or that intermittent therapies are better than continuous therapies or semi-continuous therapies. I look at these as all very complementary therapies, and it depends on what you're trying to do. In a patient who's got very, very little wiggle room of just right, CRT, in my opinion, is better because you have such tight control from hour to hour of how much fluid you can remove or leave on the patient. Other situations, peritoneal dialysis is better. There's situations where you only need therapy for 6 hours. Why are we doing it for 24 hours if we just need the therapy for 6 hours? So I'm going to leave it there and say that they're complementary. And whether you do peritoneal dialysis or hemodialysis really depends on what the situation is and what you have available. And how often you do it or how long you do it really depends on what type of balance you need to have for not only your fluid, but your phosphorus, your medications, and your uremic toxins. In hemodialysis, they're kind of a zigzag. In CRT, they're more continuous. And as you get to prolonged, they kind of become, the smoother of those sharp lines. So why extracorporeal therapy? We can gain access quickly. We can maintain tight control homeostasis. We don't need to be worrying about giving or lacking nutrition. We give them lots and lots of nutrition while they're on ECMO, while they're on CRT. We don't restrict 1 gram of nutrition from them because we have to make them fluid restricted. And sometimes, PD is not an option for us because they've had an abdominal surgery or abdominal catastrophe or have neck or have some kind of anal malformation where PD is just not going to be favorable. And again, the reasons that it's been used sparingly is because of the technology that is changing, lack of experiences or bad experiences that people have had, lack of knowledge, and other factors. When should we start kidney support therapy? PD or CRT for chronic kidney disease or for acute kidney injuries? Really, it's when you think you need to control the patient's physiology better than the patient's native kidney functions. So when your medical approaches are not likely to alter the impending harm from the inability of the organ to do its job. If the kidney can't get rid of fluid and you have a kid who's got pulmonary hypoplasia and pulmonary hypertension, you do not want that kid to have wet lungs. So at that point, even if they're not very fluid overloaded, maybe starting early to prevent that is important. I don't think that this guideline should be different whether you're a neonate or whether you're an adult or a child. Really, you're looking at your benefits and risks, and you're asking, is my patient going to be have likelihood chance to survive by me starting the therapy now than by waiting? And it's important to remember what we're trying to do. Remember, kidney support therapy does not fix the kidneys. It just does the job for the kidneys. And the jobs that we're trying to kind of help achieve in the intensive care unit are homeostasis of electrolyte, water, and uremic toxins, allowing for fluid provision so the patient doesn't have to sit there being malnourished, starving to death while you're trying to support them. And what you want it to do is to not give you problems. You don't want it to give you headaches. You don't want to freak people out. You don't want the families crying every time you walk into the room. You want to, not cause problems with hemodynamics or bleedings or vascular access. So the ways that we do it, and again, I don't have time to go through it in great detail, but I'll just give you kind of a snapshot of the ways we think about things. We're going to talk primarily about the machine, the axis, the prime, the blood flow, and the clearance rates. And we'll go through them one at a time. So there's certainly many devices that people have used in neonates. Here are some of the kind of the traditional adult-sized devices. It's important as you think about it is, what size is your extracorporeal filter volume here? You see on this first column here, the HF20 is about 60. So as Roxana said, you really need a kid to be about 6 kilos before you can avoid a blood prime. And these kids that are 93 and 72, you got to get them to be about 10 kilos to be able to avoid a blood prime. And then there's these new devices that I'll talk briefly on, the Carpe Diem, the Nidus, and the Aquadex that I've showed you before. And if you look at their extracorporeal volumes, the Aquadex is about 33 mLs. The Nidus is somewhere around 6 to 10. It depends on the size of your patient and the stroke volume of the blood that you're giving. And then the Carpe Diem has one that's 27 that's available in Europe. The 33 and the 40 are available in the United States. There's the Carpe Diem machine, and it's an exceptional machine. It's got very fine tuning of your flows. You're able to go from a blood flow of 4 to 7 to 8 to 12. You can ultrafilter 10 mils an hour or 12 mils an hour. And it's got lots of safety bells and whistles that are all incorporated. You do have to set the machine up as a daily therapy, so you have to change the circuit out every day. And you do need to prescribe the therapy for the entire procedure. So it's more of a dialysis prescription where you're saying, okay, we're going to do this for 6 hours. This is my total replacement fluid that I need. This is my total fluid removal that I need, as opposed to some of the other machines that are hour-to-hour type adjustments. And this is now available in multiple countries all over the world and growing. There's 5 programs in the United States that have it at this point. But primarily the experience has been in Europe and in South Africa up to now. And they published multiple papers. This is the first one by Enrico Vidal describing the first 13 patients, where they describe, again, low rates of hemodynamic instability at initiation and general good experiences that they've had with excellent ability to come off machines of these patients. The Nidus machine is a different circuit. It uses syringes, as you can see here, in different processes where it pushes the fluid through the hemodialysis filter and then pushes it back in a series of steps. It's currently being studied in the UK in multiple countries using a randomized cluster step wedge design in a study called the IKID study. And again, I talked to you a little bit about the Aquadex that we've been using, and to my knowledge, it's now available in another 10 institutions in the United States. And the differences here you could see are that one is that different modalities can be used for each one, and I won't go into great detail about that for the time being. From an access perspective, you got to have access that works. It also has to be small enough that it fits into the vessels of the babies. We have in our hospital kind of created this chart that basically shows that there's tunneled catheters available, untunneled catheters. We're really going to this tunneled catheter, the 6 French catheter. The surgeon cuts it to the desired length. So if you need an 8 centimeter catheter, great. If you want it to be 5, you can make a 5 centimeter catheter. We've really kind of been able to really show in this paper here, published in the Journal of Pediatric Surgery, that the rates of cardiac complications, the number of times you need to call the surgeon back and say, hey, I got a problem, you need to fix this catheter again, really goes down completely when we use these tunneled central venous catheters. Blood prime is very important if you're going to do extracorporeal therapies. In patients who weigh less than kilo, we use this formula and to calculate the extracorporeal volume, assuming in a blood volume of 80 per kilo. I'll show you just a couple of things. If you're a 4 kilo baby on the smallest circuit available, it's about 20% extracorporeal volume, again, which is perhaps okay with a blood prime. As you go to a smaller baby here, let's say a 2 kilo baby, you're now talking about a 40%. And if you're trying to do a 1 kilo baby, you're talking about an 80% blood prime. This is with the smallest filter available with the traditional adult machines, the HF20. If you go to the Aqueducts, if you have a 4 kilo baby, 10%, you can use a saline prime. So you can, from the time you walk to the bedside, you can open up the package. You're on circuit in 10 minutes. With really good hemodynamic control on a 4 kilo baby. 21% is not bad. 41%, even in a 1 kilo baby, is doable. And we've taken care of multiple babies who are as low as 1 kilo without significant hemodynamic instability. And again, you can see similar numbers with the Carpe Diem, the middle one. And you can see how this could potentially make a huge impact on your extracorporeal volume, depending on the size of the filter. In our program, anybody who's above 15% of their total blood volume gets a blood prime. Anybody between 10 and 50%, it's really up to the practitioner. And depending on what's happening with the baby, if they're hypotensive, if they're oxygen dependent, they may kind of steer towards a safer blood prime. The added risks of blood primes are important to talk about. PRBCs come as hypocalcemic, hyperkalemic, and acidotic. There's no platelets and there's no coagulation factors in this PRBC. So you just have to know about that and be ready to deal with those. In our program, we have a blood prime policy and procedure that every single patient gets, who needs a blood prime, no matter which doctor's using it or no matter which nurses doing the therapy, they do the exact same procedure. We put blood, bicarb and calcium, and I'll show you how we do that here. Here's our saline, here's our blood prime. You start with the saline of your circuit. I love this procedure because it's simple to teach and it's simple to talk about, and you'll see that in about 1 minute, you're gonna get what we do. So you have this saline circuit that you've already put up based on the company's recommendations. You take PRBCs and you take some sodium bicarb 1-to-1 to the filter, and your bicarb is about 150 MEQs per liter, and you slowly push them together until you filled up your circuit with blood. You stop the circuit, hook up the baby, and you're on. Very simple. We also give calcium to counteract the hypocalcemic environment. For our Aqueduct circuits, we give 100 milligrams of calcium gluconate. Our biggest circuits, we use 300. So that's one approach. We've used many other approaches. To me, this is the simplest one to teach and the simplest one to do, and it seems to work very well. When you talk about blood flow on extracorporeal therapies, I like to divide it into whether you're using heparin or citrate. If you're using heparin or no anticoagulation, go fast. Crank it up as high as your machine and your access allows you to. Remember that you're not taking 30 mils a minute and just throwing them in the garbage. You're taking 30 mils a minute and you're putting it right back in the same vessel at the exact same spot. So you really don't have to worry about how fast you're going, because you're pulling it off at the same rate you're giving it right back. The higher blood flow gives you improved filtration fraction, and it's harder for the blood to clot when it's going really fast. So we push it to 30 to 40, even on a 1 kilo baby, to allow us to, again, optimize our circuit life. We don't necessarily titrate our blood flow unless we're doing a blood prime. Generally, we start at half of what our goal is, and we go up after a minute. But we don't take a long time to go all the way up. We generally start at halfway for a minute. If that's working okay, blood flows are good, our access pressure is good, we go up all the way. If you're using citrate anticoagulation, it's important to just be cool with your blood flow. Remember that the clearance of citrate is based on the patient size, but the clearance of the citrate is based on the blood flow. So let me back up. So the total clearance that you're prescribing, your dialysis clearance, is based on the size, but your citrate rate is based on the blood flow. So you can get into trouble if you're using a very high blood flow, because then it gives you a high citrate flow, in someone that you don't have a high clearance on. And so you just got to be mindful and use really kind of some conservative blood flows when you're using citrate. So there's a risk for mismatch here, again, because the higher blood flow with a more citrate, but you're not clearing as much from your circuit. When it comes to clearance rates, I will tell you that there's no data to tell us how much clearance is adequate in different neonatal operational modes. Anytime you use a continuous modality like we're using, we're probably using 3 to 4 times higher clearance than PD. And really, clearance and adequacy is about making sure you have waste product removal, but it's more about fluid balance, electrolyte control, nutritional control, and growth. So should we be dosing a kid who's septic the same as the kid who has end-stage kidney disease? We don't know. Our approach is, because we don't know, we're going to do everybody the same. And at our hospital, everybody the same means everybody gets 24 mils per kilo per hour. And that's based on the KDIGO guidelines for adults with ICU. You'll find that with this clearance rate, most babies, even if they don't have any urine output, they have no kidney function, their creatinine will settle down around 1 or 1.2. We do not alter our treatment based on the duration of therapy. Again, we just go 24 per kilo, no matter what is happening. And we generally will we'll add electrolytes to our replacement fluids so that we can manage our electrolytes and they stay pretty homeostatic through the entire course. The reason we chose 24 per kilo, and the reason we don't like to go crazy with that number and say, well, let's just give 40 or 70, is because we pair this with the medication clearances that we know. If we have to go to a higher clearance for perhaps hyperammonemia, or perhaps someone who's got liver failure, or for whatever reason, we know that we communicate to our pharmacist and say, hey, look, we're on double clearance. You better give double the amount of antibiotics here. And certainly when we do CRT or PD, we add an extra amount of protein to try to maintain the urea somewhere between 30 to 50 and try to maintain enough nutrition. So I've said a lot. I will just give you a sense that this area is changing rapidly. It's very exciting. And we have a course now called the Neonatal and Infant course for kidney support. If anybody's interested to spend 1.5 days with us talking about all these things, I recommend that you sign up. We talk not only about access with the surgeons, we talk a lot with the bedside nurses. We teach about how to teach. We talk about the prescription medication. So it's really kind of a full course on not only just the technology, but really kind of how to think about your program as you start to support small children. And with that, I will stop and say thank you for this invitation, and I'm happy to respond to any questions. My email address is there if anybody wants to reach out to me that way as well. Thank you.
Thank you, David, for the excellent overview of something which is very, very challenging to, I think it is challenging to everybody. I'm sure it's challenging to you also. And for us, it is very difficult in India because most of our centers across India don't have access to all these machines. And if you have access to some of the machines, then you don't get the tubings regularly. If you get the tubing, then the family don't have money. So these are the various difficulties that we face here. So for the sake of time, we will take maybe one or two questions. There was one question a bit difficult, maybe reflecting our setup, saying that how do we perform safe and adequate dialysis through single lumen catheter in newborn, and can we use conventional hemodialysis machines for this?
What was the second question?
Can we use conventional hemodialysis machine? Can we use conventional, that is the regular hemodialysis machine, standard hemodialysis machine for dialyzing small newborns?
Yeah, I hear you. So, so let me answer that. I mean, certainly, if that's the only thing you got and you don't have peritoneal dialysis, you can. The challenge with it is that it's hard to perform it for a long duration. You could slow your clearance rates down, but if you do the traditional high, clearances, you're going to be dialyzing a lot, which is going to create a potential problem. So it's hard to do it 24 hours a day with conventional machines. As far as tell me the first question.
And how do you perform safe and adequate dialysis through a single lumen catheter?
Okay. Yeah, so we don't. I don't think it's possible to do it with this. The Nidus machine is designed for a single lumen catheter. We need a double lumen six French catheter. Some people have tried a double lumen 5 French catheter, but you need two different. You need a place to remove to remove it and a place to put it back. We've used 2 single lumens, so you put a femoral and an IJ single lumen, and you take from the IJ and replace it to the femoral. You could do it that way.
There is one more statement that can we add pot phos to Primasol because of the calcium content? Is it?
Yes. Yeah, we've been doing it for over a decade, and I can tell you there's never been a concern or a question or anybody's been alarmed that there's little rocks in the bags. I think as long as you're changing it every day and you're not giving tons of phosphorus, so we give up to 1.5 to 2 millimoles per liter. I think that we've never seen a problem.
One last question, and that's from me, is what is the advantage of Aquadex over a standard CVVH machine? Is it more cheaper or advantage of Aquadex?
The biggest advantage is the biggest advantage is the low extracorporeal volume and its simplicity. So when I talk to my neonatology colleagues, it's a very simple machine to see. Here's your pump that moves the blood around. Here's your pump that removes the fluid. Here's where I'm hooking up my replacement. Those are the advantages. It's a simple machine and it's got a low circuit volume.
Okay, thank you very much, David, for this illuminating talk. I believe you are on call or something and you have to excuse yourself. So you have already given your email. So I'm sure any of us will get in touch with you with further clarification. Thank you very much.
Wonderful, great. And I'll answer, I see some of the questions on the Q&A. I'll try to answer them before I go.
Oh, that will be lovely. Thank you very much. Okay, thanks, bye.
Thank you.
So we now move to the last part of the talk. And I believe Sukanya purposefully kept it at the last so that nobody would like to leave. Because this is something that we are in India, we require it very much. In fact, most of the time with newborn AKI, we always try to avoid starting dialysis because long-term dialysis is quite costly and often not feasible. Ruxana has already been introduced to all of us, and she's now very popular and very well known in across India. So and as well as internationally. So without much wasting time, Ruxana, it's all yours to tell us about the non-dialytic management of CKD in infants.
Thank you very much, Rajiv. And thank you, colleagues, for staying back for the very last talk. So what I'd like to do is, can you see my slides?
Yes, Ruxana, we can
Thank
see.
you. Thank you. So I'm going to talk to you about the challenges of ESKD management. I showed you this slide as the parting slide on my dialysis talk. And there are so many different aspects of CKD MBD that we need to manage, and the management of the infant with this. We have a multidisciplinary team that is absolutely crucial, absolutely crucial to the management of these complex babies. But what we mustn't forget is as each little baby comes in a family unit with their mummies and daddies. And for all of us in India, there's a whole bunch of aunties, all very well-meaning, but all sometimes a little interfering, who also tell us what they think we should do. And we have to manage this family unit alongside, of course, keeping the child at the center of it. Given the very short time we have left, I'm going to rush through these slides, but you will have access to this and in the recorded talk. So without apology, I'm going to have a brief focus on growth and enteral nutrition. Vanessa has dealt with this extremely well, but I think there are one or two things I'd just like to stress as well. I'll also talk to you about the principles of CKD MBD management, the outcomes of these babies, and again, a little bit on ethical aspects. So why focus on nutrition? The energy cost of growth is extremely high at 35% in the first month of life. And as you see in this graph here, it's highest in these early days and then drops over time as the child gets older. In addition, serum albumin is a strong predictor of clinical outcome in children on dialysis, and short stature at the start of dialysis is also a marker of poor outcome. One of our very erudite pediatric nephrologists, Alan Watson, has said, the dialysis is easy, it's the feeding that is difficult. And really, in my experience, this is absolutely true, especially for the babies. So there are so many different causes for poor nutrition in infants and children. These include the complications in CKD patients with a poor appetite, altered taste sensation, multiple medications, the vomiting and the gastroesophageal reflux they suffer, as well as the disturbed feeding history and comorbidities in the youngest ones. Also, the children on dialysis will have a number of restrictions to the fluid as well as the type of feed they can have. Dialysate losses mustn't be underestimated, and peritoneal dialysis itself can cause the feeling of a full abdomen and constipation. The International Pediatric PD Network, looking at infant growth and nutrition, identified 153 children under 2 years of age, and 40% of them were enterally fed. Interestingly, of this group, gastrostomy feeding in the blue bars here was largely practiced across North America and Europe, whereas NG tube feeding was practiced in parts of Europe and Latin America, with no enteral feeding in several parts of the world. Now, why is this enteral feeding so important, and how do we deliver it? So short term, it can be delivered via an NG tube, a nasogastric tube. But for longer term feeding, really the ideal techniques are a gastrostomy, either a percutaneous endoscopic gastrostomy tube, such as the one you see here. Sorry, my pointer doesn't work well, or an open gastrostomy tube as well. And And with this, the IPPN network showed that the assessment of growth and the height standard deviation score was the best in children who were fed through a gastrostomy for the longest period of time. So it's the duration of the feeding that mattered. Now, Vanessa has highlighted how to feed and the types of feed that are so essential, but please do remember the importance of good feeding goes a long, long way in the well-being of these children. The IPPN also showed the height standard deviation score achieved across different countries. You see that virtually all the height SDS is below 0, and several countries have a height SDS below -2 standard deviations. This is not to name and shame anybody or any country. I am Indian too. But you will note that for India, the height SDS is particularly low. So even as we all focus on a dialysis meeting on the fanciest of new dialysis techniques, please remember, start from the basics and focus on growth. Okay, moving on now to calcium and phosphate dysregulation in CKD. You're all familiar with these figures of calcium, phosphate, PTH, 25-hydroxy vitamin D, and the very tight and negative feedback control between these different pathways. What is important to remember is that infants and children need calcium. This graph here shows the age across the years going from birth to 100 years and the bone skeletal content. So the youngest children at birth, we have a bone calcium content of just simply 25 grams at birth. And this increases to a total of 1.25 kilograms in an adult female and 1.5 kilograms in an adult male. So the calcium intake or accrual by the skeleton is almost exponential, particularly in the first few years of life. And we do know that children with a low bone mineral density tend to fracture. On this note, the daily calcium balance is highest in the first year of life and is a positive 500 to 600 grams per day, which is higher than at any other age. Therefore, the normal serum calcium levels are also high, as you see in this graph, highest in the first 12 months and coming down to adult levels only by about 4 years of age. The dietary calcium intake, therefore, is very important to be regulated. This graph shows that the dietary calcium and phosphate are very closely related. And this is, of course, because most foods that have calcium, such as dairy foods, also have phosphate. And a number of our children will be phosphate restricted because of their CKD. Therefore, looking at this graph here, you see that compared to healthy people in green, healthy children in green, the blue bars show the dietary intake from calcium and medications, and the pink bars, which are way down here and well below the recommended nutrient intake, denote the calcium intake from diet alone. This suggests that a phosphate-restricted diet does not give enough calcium, and one does need to provide calcium through medications, most commonly through calcium-based phosphate medications, to meet the calcium intake for children. So let's look at phosphate now. Just as with calcium, the phosphate upper limit is also higher, and serum phosphate levels are highest in infancy, and very similar to calcium levels. The phosphate content of breast milk is low, and so is the content of whey-based formulas. But despite this, children, and particularly those with a low urine output, will require phosphate binders. Some of you will be familiar with this graph from the IPPN. This is data on over 900 children on dialysis. And if you look at the column here for the under 1-year-olds, only 6% of them are hyperphosphatemic. In contrast, 80% of adolescents are hyperphosphatemic. I don't think this is a biological variation in people over age. It is simply the fact that a good controlled phosphate intake in the youngest children achieves good phosphate control, and it is something that can be done through dietary control and the judicious use of binders. So this takes us to the dietary phosphate management. And here our goal should be to keep serum calcium and phosphate in the age-appropriate normal range, but most importantly, without compromising nutrition. Children who are hyperphosphatemic or have hyperparathyroidism will require a dietary phosphate restriction in the first instance, potentially to bring this down to the lower limit of the SDI. Vanessa has explained this concept to you. And where the phosphate cannot be controlled further by diet, one needs to add in phosphate binders. Both KDIGO and the NICE Institute in the UK have recommended that calcium-based phosphate binders are the first-line treatment for children and most definitely for infants. I've put this bit here in brackets, but in the older child or as weaning starts, you must consider the source of phosphate, keeping in mind animal, vegetable, and additives all have different bioavailability. The calcium-based phosphate binders, calcium carbonate and calcium acetate, differ in the elemental calcium content that they have, but most importantly, in particularly children who are on continuous feeds or tube feeds, calcium carbonate is much easier to dissolve in feed, much more soluble and easy to administer, as well as cheaper than calcium acetate. Some important things with phosphate binders are that they should always be given with feed or food, and especially with high phosphate snacks in the older children. Calcium carbonate requires an acidic pH to dissolve, so the normal gastric pH to dissolve into calcium and carbonate and dissociate rather, and only then will it be effective. So do not give it with ranitidine or omeprazole or similar medications. Also, the calcium will precipitate in the duodenum, so do not give it with bicarbonate-based supplements, and nor with iron preparations, phytates or oxalates. With this in mind, to quickly go to vitamin D now, the RNI or recommended nutrient intake of vitamin D is about 8.5 micrograms, reducing over time to about 7 micrograms as the infant gets older. Breast milk, particularly if the mother is deficient, and also standard whey-based formula has a low vitamin D content, and therefore babies do require vitamin D supplementation until they are on sufficient volumes of feed. Now, the type of vitamin D here is native vitamin D or ergo or cholecalciferol that we're talking about. In addition, an infant in CKD stages 4-5 or on dialysis will also require a vitamin D analog such as alpha calcidol or calcitriol. Now, I put this slide up here only to tell you what not to do. Do not use cinacalcet in neonates, and with extreme caution in older in children. It's not licensed below the age of 3 years. These children need calcium. They can die from hypocalcemic seizures. So please do not use it unless with extreme caution or in some rare genetic conditions. Let's move now to some practical tips for dietary management. We, as Vanessa told you, we are part of the Pediatric Renal Nutrition Task Force. We arrange a number of webinars, all freely available, and we encourage you to participate in these for further practical tips on the dietary management of calcium and phosphate, of enteral tube feeding, and most aspects of nutrition. With this, let's look at a few outcome measures. So I mentioned this excellent study, registry data from Van Stralen et al., looking at 5 different registries. And here they show the height Z-score over the first 3 years of life. You will see that almost all children are below -2 standard deviations, but those who have comorbidities in the sort of squares boxes have the highest, have the lowest height Z-scores. Looking at neurocognitive outcomes, this has been described in very well by Professor Warady et al., comparing the patient with their siblings and showing that for almost all aspects of neurocognitive function, the patient fares worse than their sibling. I briefly mentioned the ethics of infant dialysis in the previous talk, and this is certainly a topic that merits a great deal more time and discussion. But briefly, the burdens of the dialysis therapy on the family, the uncertainties about outcome have led to a situation where renal replacement therapy is desirable but not obligatory. And this is really something important to think through and digest, and each child and each family unit must be treated individually. So physicians were asked in this excellent survey across about 270 nephrologists in these 5 countries whether they would offer or recommend renal replacement therapy for some or all infants. You'll see that the majority of people said they'd offer it for some infants, but there was a much more conservative response when asked if they would offer this for all infants. Now remember, this is chronic renal replacement therapy, not acute short-term CVVH or PD, as we discussed previously. And of course, it's a matter of judgment and quite a difficult call sometimes to know whether this is going to be a dialysis you need is going to be short or long-term. Now, interestingly, these same authors then went on to ask physicians if the parents had a right to refuse dialysis. And these same physicians across different countries said that in a neonate under 1 month, one third of physicians said that the parents had no right to refuse. In older children from 1 to 12 months of age, 50% of physicians said that the parent had no right to refuse treatment. This is a difficult and an interesting concept. We cannot take away the parent burden and how it impacts on so many aspects of their lives, for the parents, for the siblings, for the household situation in general, how we are medicalizing the parenting of these families, how it can lead to ill health, mental health breakdowns, and extreme distress. So I think we have to be very, very careful how we and look at medicine as a social science, interpreting the need of this in your own particular countries and circumstances. In particular, we must keep in mind the comorbidities that neonates can have. And again, this Van Stralen registry data shows that 73% of neonates have some comorbidity. And often this can be neurological in nearly a quarter of patients and lead to developmental delay in a further 20%. So the patient survival, again described in the Van Stralen registry, was 5-fold higher in those with neurological disorders, again putting some perspective on the patients we accept or consider not to accept for long-term dialysis therapy. With these factors in mind, the European Pediatric Dialysis Working Group suggested the following factors when considering starting RRT in an infant. First and foremost, the comorbidities in the child, the predicted quality of life for the child and family, the availability of resources, both medical, but I think equally or more importantly, the family support available in the long term, and the prognosis and possibility of future transplantation. And so I'm sorry, this is a very quick whistle-stop tour, but to briefly summarize, early intervention is critical to prevent malnutrition rather than work on treating it. So invest it and work very closely with a pediatric renal dietitian and consider enteral tube feeding sooner rather than later in the course of ESKD management. Neonates and infants have a high calcium and phosphate requirement, and prevention of mineral bone disease is as important as trying to treat it. And carefully consider the decision of starting chronic RRT, working in partnership with the family. Thank you very much. And I look forward to a discussion with you.
Thank you, Ruxana, for that whirlwind tour of managing newborn security. And I think what you managed to really emphasize is that highlighting the importance of nutrition, because I mean, as you say, and we all remember Leslie saying that that is the most important thing ensuring the appropriate nutrition. And we in India, we have like struggled with this, like convincing our infant to go on gastrostomy. And yeah, it is quite sad that at the moment I have got only 3 infants who are on gastrostomy.
It's
And
sad, but there's no reason for that pattern to continue. Yes. So I know this is a dialysis conference, but I'm still going to say perhaps even more important than the dialysis is feeding and feeding well your infants with CKD.
We completely agree, but I don't know whether Dr. Sushmita wants or Sukanya wants to add anything to this. But in my experience, we have found quite an aversion on the parents, and most of the time we have been unable to convince the parents. The concept that there will be a hole in the stomach, that itself seems to be quite difficult for them. But we are improving, because in the last 1.5 years we had 2. So I think we are improving. If Susmita wants to take up some of the questions for Vanessa or Ruxana.
Can I quickly ask a couple of practical questions? Ruxana, when you have small babies starting off on dialysis, either PD or hemo from a very young age, and then they grow up with all these lines in, do you actually need to change your lines, either your PD catheters or your vascular catheters?
Very good point, Sushmita. So the PD catheters, when they're curled, when they have a coiled end, they're long enough to stay in there. In my experience, I've had to change only one hemodialysis line in 20 years, because for the simple indication that the child grew so fast that he outgrew his line. And this is extremely unusual. If you can get your child to grow that well, then bravo, well done.
Okay, so you do need to occasionally, but it's rare.
Extremely rarely, yes, extremely rarely.
Okay, and another really practical issue that we face, Vanessa, if you could help us with this, if you get a child who is already suffering from significant failure to thrive, how do you calculate your intakes, your energy and protein intakes based, you wouldn't want to base it on the current weight, I guess. Do you look at the ideal weight for age? What do you use as your baseline?
We would use the child's actual weight rather than their expected weight for their age, because otherwise you can be completely overestimating how much energy and protein they need. And it would be very difficult to get that prescription into the smaller child, the smaller baby. So we would always calculate energy and protein requirements, certainly up until 2 years of age, on the child's actual weight rather than the expected intake for their age.
Okay. And then you would adjust according to the outcome, according to the gains that you saw?
Yes, I mean, the key thing is regular measurement, so that we can, and particularly with young babies, we might be weighing them every week, so we can detect very quickly when they're falling off their centiles and when we need to be more aggressive with the amount of energy that we're giving them. Obviously, it's more difficult. You need a longer period of time if you're looking at their length to see if nutrition's had an impact on it. So really, we're taking regular weights as a proxy for their rate of growth.
And, in India, you may know that many people are quite strictly vegetarian. Does that make a difference to providing adequate calories and protein?
Certainly not with protein, as long as you're using a mixture of cereals and pulses so that you're getting the full range of amino acids. I mean, a plant-based diet can be perfectly adequate in protein, but it mustn't be heavily focused either on cereals or on pulses. You need to have a mixture of the two, ideally at every feeding time, so that you get a good, the right distribution of amino acids to support that growth. It sometimes is that vegetarian diets are lower in energy, but again, you can supplement with energy, as I suggested, by adding sugars and fats to the diet to bring the energy level up.
Okay, great. Just coming to the questions. Rajiv, do you want to take them up or shall I
Yeah,
start?
there are a few questions related to PD, Ruxana. One is how do you manage high phosphate and creatinine in a baby on PD who is otherwise a high transporter and doesn't generate enough UF if the dwell time is prolonged? I think we have covered the phosphate part in your talk, but then overall, do you want to say anything on this, as well as your experience in using icodextrin? I remember that when we were working together, we had just started using icodextrin in at that time.
Oh, that was a long time ago, Rajiv. So we've been using icodextrin for nearly 18 or 20 years now, and it's very, very good and effective. So to address the question, yes, it is certainly, somebody has correctly mentioned that it's almost you need to adapt your PD program differently to remove fluid and to manage the small electrolytes, the small molecules such as urea and potassium, and differently to remove phosphate, which has a different dynamic of removal. So for phosphate removal, one really needs longer hours, which is achieved with a last backfill. So the last backfill or the day dwell on an APD regime is absolutely essential. Now, for the day dwell, one can use icodextrin. You have to be a little bit careful in the very small infant or neonate. Definitely do not use it in a neonate. Use it only after about 3 months of age, and be very careful because icodextrin can cause hypotension with a sudden removal of fluid. So the first few sessions with icodextrin must be in the hospital with careful monitoring of BP and weight. And thereafter, you can safely use it at home. And it is indeed very effective for both fluid as well as for phosphate clearance.
I remember that there was a lot of talk about icodextrin getting accumulated in bones or somewhere. And
Rajiv, you have a good long-term memory. We are not worried about that now. Sorry, I'm giving you quick answers because we're far behind time. Yeah, we don't worry about that. Thank you.
And there was another question about with a child with severe acidosis, do you prefer a bicarbonate-based PD upfront?
I prefer bicarbonate-based PD for all infants because it is more biocompatible and it causes less peritoneal irritation. It also causes less pain, and particularly in those children who might experience pain. In the circumstance of severe acidosis related to a metabolic disorder, an inborn error of metabolism, for example, like methylmalonic acidemia, then I would insist on a bicarbonate-based fluid. But otherwise, if you have only Dianyl, which is lactate based, and you do not have a choice, the PD is still life-saving, and the bicarbonate in that situation is a luxury item for you.
Do you have a weight cutoff for offering PD to premature neonates? I believe they mean long-term PD.
Yes, well, a good question. I guess if it's a life-saving treatment, we have tried it. We've tried it in 600-gram babies. Of course, this is a rare event, but in babies more than 1 kilo, yes, we have tried it. We have done it regularly and with success.
This question is for Vanessa, and Susmita Devi will also remember. This is something that we were discussing, in fact, last week or the week before. Can we give, can we exceed the protein limit of the KDOQI for growth? If the growth is inadequate, can we exceed the protein limit? Like, can we give more than what is recommended?
Yes, you can, as long as it's not going to result in pushing up urea levels. I mean, the ranges of the suggested dietary intake or the KDOQI recommendations are a range of where to start from. And if a baby is taking more protein than the recommendation, or you're prescribing more, then that's not a problem, as long as you're not pushing them into being uremic because you're doing that. I mean, the important thing is not to go below the lower end of the range, but if you're going above the higher end of the range, it's not going to cause a problem if there's sufficient energy for the child to metabolize that protein. But obviously you do need to watch your urea levels, because they can start to shoot up if you're giving as much as, say, 3 grams of protein per kilo. That's probably quite generous for a child with, or a baby with CKD, whereas that would be fine in a normal child with a healthy kidney.
Any cutoff of urea BUN that you start getting worried about?
Well, it's interesting because the Nutrition Task Force debated this for a very long time to say, could we give acceptable levels of urea? And there's no evidence as to what acceptable levels are. And all of the experts around the table, the nephrologists and dietitians, all had a different cutoff point. So it's very difficult to say. I mean, just my rule of thumb was that for an infant, I would try to keep their urea level below 15 millimoles per litre. But if it's higher and they're not suffering uremic symptoms, then maybe it's acceptable. And some children do tolerate and adapt to a higher urea level.
Sorry,
So,
Vanessa, may I add one quick thing to that, please?
Yes.
Just to say that swings in urea level, up downs in urea level are much more dangerous than a consistent high level. And it is the swings in urea that can cause dialysis disequilibrium. So for example, if a little baby with a very high urea were going for a living donor transplant, where the urea will suddenly very quickly come down post-transplant, you need to be a little bit careful in that situation. But otherwise, a chronically stably high urea is not dangerous. Thank you.
I think that answers it. And again for Vanessa, how about keto analogs for neonates or pediatrics?
There's no evidence to show that keto analogs are beneficial in pediatrics at all. And indeed, we wrote that into our clinical practice recommendation. So that's the short answer.
Another one maybe on the ethics, like for Ruxana, that would you dialyze a premature baby with ARPKD and also having pulmonary hypoplasia?
I think that answer is depends on the severity of pulmonary hyperplasia and if you think this poor child is going to survive with these lungs or not. That's the sad but obvious answer. If they cannot survive with their pulmonary complication, then I wouldn't burden them with dialysis. That would be quite pointless.
One more for Vanessa. I lost it in the just flooding in. Where did? Yeah, for vitamin D deficiency, would you give 4,000 international? So we have a vitamin D deficiency of less than 5 nanogram per ml, so very severe. The question is that would you give 4,000 international unit daily, way more than the recommended dose? Or
I can't answer that one. Could you answer that, Ruxana?
Ruxana, yeah.
Yeah, I would. 4,000 international units daily in a neonate is an extremely high dose, perhaps unnecessarily high. I would perhaps give them 1,000 or 2,000 international units daily, repeat levels within a month to make sure you're not toxic, not to achieve normal levels, but to avoid toxicity from overdosage, and then to adapt the level down to a more conservative one soon.
And this is for Ruxana, something I am sure she will like it, about growth hormone in CKD. So when you do like to use growth hormone, what is its effect on high urea and creatinine level?
So the second part of the answer is easy. We've published guidelines from the ESPN CKD dialysis working group, and all details are available in that. There is adequate literature to confirm that growth hormone does not adversely affect urea or creatinine or worsen the CKD stage. Which patient to use it in requires some thought. I think the first and foremost thing is you have to have good nutrition and the best possible nutrition you can achieve for that child. And if this still does not achieve an adequate growth velocity or the growth centiles are just simply flat, then one can consider growth hormone. I'm not averse to growth hormone, but I very, very passionately believe that there is no use using growth hormone, no purpose using growth hormone unless nutrition is optimized first.
Yeah.
And could I just add that the amount it costs to have a child on growth hormone for a year would probably pay the salary of a dietitian and for their training. So I would rather you spend your money on dietitians, not growth hormone.
Absolutely.
That's excellent. I think once when we came back, that was one of the main message that Leslie was able to impart on us, that before growth hormone, start thinking about diet and nutrition. I think we'll take this as a last question, like something on the anemia management in CKD among infant and newborn, like anything different, any dose of the EPO different, anything.
Yeah, I didn't have time to touch on this, but it's a good point. Of course, again, ensure adequate iron stores, exclude hemoglobinopathies, and make sure other deficiencies such as B12, folate, and copper are corrected, not present or corrected, and then use erythropoietin. Usually in the babies, they need a relatively higher dose, between 100 to 300 international units per kilo per week. And this can be done as a single weekly or a twice weekly dosage.
I think we have covered most of the questions. There are one or two left, and it is always nice to have something left for the next year. I'm sure Sukanya will be doing this regularly, and we in India would like to have dinner, which Sukanya is not sponsoring. So, if Susmita-ji, anything else you want to add? Otherwise, we can
No,
thank
thank you. I
everyone.
think it was a really great couple of days. Thank you to all the faculty and to the organizers.
So thank you, Ruxana. Thank you, Vanessa. And over to Sukanya.
Yeah, thank you very, very much. Not only to the delegates, but especially to the faculty of the last session. Thank you for staying back. I had to hard maneuver some of you to stay back and take all the questions, but the delegate count was so strong, and there's so much of email questions to me, emails asking me to take the questions. That shows the interest and the expertise of the faculty. Very, very well done. I'm so happy that I did this, and I'm so happy that all of you could join today. We'll try and put some of these on the IPNA website, and if the speakers allow, we can sort of put some of these lectures on the YouTube. Again, many thanks for all of you, especially the faculty, for joining in. We had an excellent 2 days. As a delegate, actually loved all the talks. Loads of learning, loads of learning. I hope everyone else also benefited from it. But I know I'm not going to keep you any longer. Have a nice day ahead. And in India, we are I think close to midnight almost. Thank you for staying back, all the delegates. Excellent session. Dr. Ashkenazi, really wonderful, wonderful session. We delayed you so much, but then yeah, you rocked it really. The session was really, really good. Ruxana and Vanessa, really excellent, and really appreciate you staying back for the talks. Dr. Ashkenazi has raised his hand. Sir, please, would you like to say a few words?
No, I was just going to say thank you, and I appreciate your inviting me to this. So thumbs up.
Yeah, thank you very much.
Great sessions.
Well done to you, Sukanya, for organizing all this. Sukanya, Lakshmi, and colleagues, well done.
Today.
Well done, all of you.
Wonderful, wonderful job.
Thank you very much, Sukanya, and hope to have this more face-to-face next time.
I would love to host you all in Chennai for a physical meeting where we don't have these technical difficulties. I hope we'll get there soon. Yeah, thank you very much.
Bye. Bye, everyone.
Bye. Good night.
Bye. Bye-bye. Take care.
Thank you.